Hello. Hello, good afternoon. Good afternoon, everyone. Hope you all are doing good. Okay. Just a second. Yeah. Okay, guys, before starting this session, let me be just clear. This session is for INI-CET, but not only just for INI-CET. The ones who are preparing for FMGE or NEET PG, they can also go through this session. Okay. Before starting the session, again, this is an MCQ format session. So, before starting the session of anesthesia, let me give you a brief introduction of anesthesia so that you can understand. Guys, remember, anesthesia is basically you make the patient numb before performing any painful procedure. Okay? If you are making a small area numb, that is called as local anesthesia. That is called as local anesthesia. Or if at all the patient is posted for some surgery below the level of umbilicus, he requires anesthesia only for below umbilicus. So you need to go for spinal anesthesia. Spinal anesthesia. But if some patient is coming to you for below umbilicus surgery, but the surgical duration is like 4 to 5 hours. If the surgical duration is 2 to 3 hours below umbilicus, you go for spinal. If the surgical duration is more than 3 hours, if it is below umbilicus, then you go for epidural anesthesia. Epidural anesthesia. Okay. But basically, you need to remember in local, spinal, and epidural, the patient is conscious. Now, if the patient is posted for above umbilicus surgery, such as cardiac surgery or any CNS surgery, then we need to go for general anesthesia. General anesthesia is you make the patient fully numb or fully unconscious. As you can see over here, in general anesthesia, what we are giving to the patient, we are giving some mask to the patient. Why? Because your patient, here you are making the patient unconscious and you need to maintain his oxygenation with the help of mask ventilation. Lecture duration mostly 2 to 2.5 hours. Okay. Right. And there is one more anesthesia technique which is called as nerve blocks. Nerve blocks means what, guys? Nerve blocks means you are selecting a plexus of nerve and you are blocking it. Imagine a patient is posted for some fracture of the upper limb. You select a plexus of nerve that is supplying the upper limb, that is brachial plexus, and you just block that brachial plexus. Okay, so that is one example, guys. Brachial plexus is one of the example of nerve blocks. There are many nerve blocks. Now, starting with the first MCQ. Remember, whole topic of anesthesia revolves around these 5 techniques of anesthesia. Okay. Now, coming to the first MCQ, guys. A 28-year-old primary gravida in labor receives labor analgesia, epidural analgesia. Shortly after receiving this epidural, she develops tinnitus, metallic taste, and circumoral or perioral numbness. What is the most likely cause of it? Okay, we are not talking about epidural, we are not talking about it, but you need to understand, guys, after placement of epidural catheter, should the patient complain of this? No, the patient should never complain of this. If the patient is complaining, what does it mean? Remember, epidural anesthesia means you are placing an epidural catheter and you are giving the drug inside the epidural space. If you place the catheter in the epidural space, there is no complaint of these symptoms. But by mistakenly, if your catheter reaches the intravascular compartment, or it reaches some vessels over there, it can happen, guys, and you have injected the drug directly intravascularly. So what could happen in this case? Sir, what type of anesthesia is given to patient with neurosurgery but the patient is awake? That is called as conscious sedation. Okay, conscious sedation. FMG के लिए, INI-CET के लिए, सबके लिए ये lecture, ठीक है? So over here, guys, just look over here. We were discussing about what? Our epidural catheter might have gone into the intravascular compartment and if you give the local anesthetic through the intravascular compartment, the patient will land up into what? Patient will land up into local anesthetic systemic toxicity. And once the patient develops local anesthetic systemic toxicity, patient will have circorol. The first complaint of the patient is what, guys? When local anesthetic systemic toxicity happens, patient complains of perioral numbness followed by tremors or seizures or metallic taste also. Okay. Now, why it cannot be a high spinal block? Remember, guys, if high spinal block, when does it occur? If at all your epidural catheter might have undergone inside the dura and you have given the drug in the CSF, then high spinal. If high spinal occurs, these symptoms won't occur, guys. If high spinal occurs, patient will have hypotension or bradycardia. So that is being ruled out. Okay? Accidental intrathecal injection also, it's similar to high spinal. Basically, you are giving the drug inside the CSF, patient will have this symptoms. Okay, so the answer for this is local anesthetic systemic toxicity. Now, guys, before proceeding further, we need to discuss something about local anesthetic drugs. What are local anesthetic drugs? These are the drugs which are given in all anesthesia techniques. What all anesthesia techniques? In local you give it, in spinal you give it, in epidural you give it. Okay, except for general anesthesia. So remember, guys, I told you that in this case the patient had land up into local anesthetic systemic toxicity. But when you are giving local anesthetic drug, there are some sites where if you give local anesthetic drug, then the chances of toxicity is very high. Why? Because the absorption rate of local anesthetic is high when it is given at those sites. What are those sites? Local anesthetic toxicities is high when it is given through the IV route, followed by tracheal route, followed by intercostal route, followed by brachial plexus. Okay? Why? Because here there is high abundant blood supply, and if you give local anesthetic, then the chances of toxicity are high. So now when we are discussing about local anesthetic drugs, remember when we give local anesthetic, what is the main mechanism of action? That has been an MCQ, guys. The main mechanism of action of local anesthetic is to block the sodium channel. It can block the other channels also, but the main mechanism is sodium channel blockade. But how is it blocking the sodium channel? When you give local anesthetic, it enters the nerve in non-ionized form. Once it enters the nerve in the non-ionized form, inside the nerve, it changes itself into ionized, and this ionized form goes towards the voltage gated sodium channels and it blocks the sodium channel. So which channel, basically which form of local anesthetic is blocking the sodium channel? Ionized form blocks the sodium channel, and the main mechanism is basically the sodium channel blockade. And these local anesthetic drugs are classified into two categories. One is called as amino ester, other is called as aminoamide. By looking at the name, we can say whether this drug is an amino ester or whether this drug is an aminoamide. Why? Because remember, in amino ester, the spelling amino ester, how many alphabets of I are there? Only one alphabet of I is there. So all the drugs which are in amino ester category will have only one I. Example: cocaine, procaine, benzocaine, tetracaine, proparacaine. Now you might be confused. Cocaine was in local anesthetic. Yes. Now it is the most abused drug, but back in those days, it was the first introduced local anesthetic used for eye surgery and spinal anesthesia. Okay, but remember, cocaine is normally all local anesthetic will call vasodilation, but cocaine is the only local anesthetic that causes potent vasoconstriction. Very, very important point, guys. Potent vasoconstriction. That's why you might have seen most of the cocaine users or cocaine abusers, they are usually hypertensive, or if are not managed properly, they will land up into stroke. Why? Because cocaine causes potent vasoconstriction. Okay? Proparacaine is most commonly used local anesthetic for ocular surgeries. Right? Next category of local anesthetic. Next category of local anesthetic is what, guys? Next category is called as aminoamides. In aminoamides, how will you identify aminoamide? Remember, okay. Yes, I promise you after the lecture, PDF will be delivered from my side, and I'll make sure that it reaches to you also. Okay. Right. Aminoamides. Aminoamides are the local anesthetic which are having two eyes. Two eyes means what, guys? Remember, all local anesthetic which are having two eyes comes under aminoamide. Lignocaine, mepivacaine, bupivacaine, prilocaine, dibucaine. Remember, guys, in these the most commonly used local anesthetic worldwide it is always lignocaine. Most commonly used worldwide is lignocaine. Apart from that, what else we need to remember? Bupivacaine. Bupivacaine is the most commonly used local anesthetic in spinal anesthesia. Why? When we are having a common lignocaine, why do we use bupivacaine in spinal anesthesia? Why? Because bupivacaine is having a longer duration. But even though it is the most commonly used in spinal, it is the most cardiotoxic. Most cardiotoxic meaning what, guys? It can cause cardiotoxicity and arrhythmias if it is given intravascular. If you give in the CSF, there is no chance of cardiotoxicity with bupivacaine. Okay. Now, guys, remember, whenever you give a local anesthetic for any purpose, whether it is for spinal, whether it is for epidural, whether it is for anything, it will usually act for a limited time of duration. Example, lignocaine usually works for 45 minutes to 1 hour. But if you want to increase the duration of lignocaine, you can add something to the local anesthetic, or you can add something to the lignocaine. That is called as additive, guys. Okay? In additive, what are the drugs which are used as an additive, guys? In additives, we are using adrenaline, we are using soda bicarb, we are using opioids. In opioids, all opioids can be used except remifentanil. Remifentanil is avoided in spinal anesthesia. Why? Because remifentanil contains neurotoxic preservative. Okay, all opioids means what? Alfentanil can be given, sufentanil can be given, fentanyl can be added, guys, to local anesthetic to increase the duration. Okay? Opioids are most commonly used. And what is the most common side effect of opioid when you are mixing with lignocaine and giving? It is increasing the duration, but the side effect what the patient might complain of is pruritus, allergic reaction. Okay, that's regarding what, guys? That's regarding the additive. Now, guys, remember, we are discussing something about allergic reaction, so we need to discuss. Remember, I told you opioids can cause allergic reaction, but is there any chance that local anesthetic itself causes allergic reaction? Yes. Local anesthetics belonging to amino ester category can cause allergic reaction. Okay? Why they can cause allergic reaction? Why? Because some of the local anesthetics are metabolized to a compound called as PABA. PABA is nothing but para-amino benzoic acid. Okay? So that can cause allergic reaction. And which local anesthetic can cause allergic reaction? These are usually the amino ester local anesthetic that can cause allergic reaction. In the amino ester category, guys, which two amino esters can cause allergic reaction? Remember, if you look at the spelling of PABA, P-A-B-A, concentrate on the enlarged P and the enlarged B. The local anesthetic starting with P and B can cause the local amino ester starting with P and B and can cause allergic reaction. P stands for what, guys? Procaine can cause allergic reaction, and B stands for benzocaine can cause allergic reaction. Okay? Next. Which of the following is regarded as the shortest acting local anesthetic? Okay? Lignocaine, bupivacaine, dibucaine, chlorprocaine. Which is regarded as the shortest acting? If anyone asks you this question, you have to remember with the mnemonic. Longest to shortest acting local anesthetic, the mnemonic is what, guys? The mnemonic is Delhi to Bombay loves PC. Delhi to Bombay loves PC. PC could be Priyanka Chopra, Prem Chopra, or any Chopra. Okay? Pariniti also. Okay? So anyways, Delhi to Bombay. D stands for what, guys? Dibucaine. This is the mnemonic for longest to shortest acting local anesthetic. Dibucaine. T stands for tetracaine. Okay? B stands for bupivacaine. L stands for lignocaine. P stands for procaine. And the shortest among all is what, guys? Chlorprocaine, or you can also say chloroprocaine. Okay, so remember, this is the longest to shortest. Dibucaine is regarded as the longest, but still we are not using it. Okay, why? Because it's the most toxic local anesthetic. Tetracaine is also long, like a bit short than dibucaine, but still it is not used. Why? Because it's having toxicity towards various systems. That's why most commonly we are using which one in spinal anesthesia? The most commonly used in spinal anesthesia is always bupivacaine, even though it is the most cardiotoxic local anesthetic. Okay, but remember, in spinal anesthesia, we are giving the local anesthetic drug in the CSF. No chance of cardiotoxicity. But if you give directly, like while giving spinal, if you give the drug directly inside the blood vessel, then there is a chance of cardiotoxicity. Okay, Most commonly used lignocaine and procaine, and last is chlorprocaine. Remember, procaine is the safest local anesthetic in malignant hyperthermia. Usually almost all local anesthetics are safe. There is a rare chance of malignant hyperthermia with lignocaine. The only local anesthetic which can cause malignant hyperthermia or trigger malignant hyperthermia is lignocaine. That too very rare, guys. Okay, that's regarding broad gauge. That's regarding longest to shortest. Now, among all these, the most important one is lignocaine. How to remember the important points of lignocaine? With the alphabet LIG, sorry, with the spelling LIG of lignocaine, you have to remember the points of lignocaine. Okay, L stands for what, guys? In lignocaine, lignocaine is the most commonly used local anesthetic worldwide. Okay, worldwide. Next, with I, what you need to remember, guys, lignocaine is most commonly used local anesthetic in a technique called as IVRA. IVRA is nothing but intravenous regional anesthesia. Basically, you are placing a tourniquet over here, okay, and then you give, with the help of cannula, you inject a local anesthetic which will be blocking only this part. Only this part will be blocked. The drug cannot reach the systemic circulation. Why? Because you are applying a tourniquet. Basically, you are achieving a regional anesthesia through the IV route, that is called as intravenous regional anesthesia, and most commonly used drug in IVRA is lignocaine. G stands for what, guys? G stands for garmi. Garmi means what? It is the local anesthetic that can cause garmi. Garmi in the sense, in English term of garmi, what is it called? High temperature or hyperthermia. So lignocaine can cause malignant hyperthermia. There is a rare case, but it can cause malignant hyperthermia. It can trigger malignant hyperthermia. Okay, so with that, you have to remember this, and you also need to remember the dose of lignocaine. What is the dose of lignocaine, guys? When you are giving lignocaine in a plain dose without any mixture, without any mixing of opioid or any drug, plain lignocaine should be given in a dose of 4.5 mg per kg body weight. But with adrenaline, it should be how much? 7 mg per kg body weight. With adrenaline or opioid, the dose you can increase. But if you exceed the normal dose, 4.5 was a normal plain lignocaine dose. But if you give a lignocaine in a very high dose, there is a chance of lignocaine toxicity. Or if you give lignocaine inside the blood vessel, there is a chance of toxicity. And if lignocaine causes toxicity, which system will be commonly affected? The central nervous system. The first sign of lignocaine toxicity is what? Patient complains of tingling and numbness near the lips. That is called as perioral numbness. Perioral numbness. Okay, that is regarding lignocaine, that produces CNS toxicity. But if you give bupivacaine inside the blood vessel or in a higher dose, then it will cause what toxicity? Bupivacaine always causes CVS toxicity, cardiovascular toxicity. And if cardiovascular toxicity occurs with bupivacaine, patient will have arrhythmias. Those arrhythmias are usually managed with amiodarone. Okay, but what is the treatment of choice? If the patient develops local anesthetic systemic toxicity, LAST, the treatment of choice is always what? It is always intralipid solution. Very, very, very important. Intralipid solution. How much percentage? 20% of intralipid solution should be given. Okay, that is regarding the toxicity. But remember, lignocaine causes central nervous system toxicity and bupivacaine causes cardiovascular toxicity. Now, guys, coming to this technique, what is this technique being performed over here? What is the technique that is being performed over here? Just now I have explained you. You are seeing a tourniquet and you are seeing drug given on the same hand. Normally, if you apply tourniquet, drug should be given on the other hand. But if you see the tourniquet and drug both are given on the other hand, that means you want the drug only to act till this level. You don't want the drug to go up. This is called as IVRA, also called as Bayer's block. What is the most common local anesthetic which is given in an IVRA? It is lignocaine. Okay. And while performing IVRA, what is the pressure inside the tourniquet for upper limb? In upper limb, it should be 50 plus systolic BP, whereas in lower limb, the pressure should be 100 plus systolic BP. Normally, just assume our systolic BP is 100. So 100 plus 50 is 150 for upper limb, and lower limb 100 plus systolic means 200 of pressure you have to maintain. But one drug should never be given in IVRA. What is a drug which is contraindicated in IVRA? Bupivacaine. Why, sir? Why bupivacaine? Why? Because just now I told you bupivacaine should never be given intravascular. Bupivacaine. It can cause cardiotoxicity. Okay. Next. A nurse applies EMLA cream. EMLA is nothing but eutectic mixture of local anesthetic. Normally, child who are having needle phobia, first we apply EMLA cream and then we place a cannula for them. Okay? The child cries in pain. Immediately after applying EMLA, she tries for venipuncture. The child cries in pain. What went wrong? EMLA is usually given to reduce the pain. What went wrong over here? Was the wrong drug given, insufficient dose was given, allergy, or an inadequate time for onset? What's the answer over here, guys? Remember, EMLA when you are applying, you have to give some time. How much time will it take? Usually 1 hour is the minimum time for EMLA to act. Okay, but what she did, immediately after applying, she tried to put the cannula, child will cry. So remember, guys, the answer over here is what? Answer over here is inadequate time for onset. Now coming to EMLA. EMLA is nothing but EMLA is eutectic mixture of local anesthetic. What local anesthetic are we talking about? 2.5% prilocaine and 2.5% lignocaine is there in EMLA. When you apply this EMLA, for which patient you apply for this EMLA? Usually for pediatric patient you apply for EMLA. Adults, if you want to harvest skin graft and all, you can apply EMLA. But remember, EMLA is contraindicated in neonates. Why, guys? Why should it not be given in neonates? Why? Because if you apply an EMLA cream in neonate, what will happen? The prilocaine component of the EMLA, it usually gets absorbed through the neonatal skin, and it gets metabolized to a compound called as O-toluidine. And what does O-toluidine do? O-toluidine usually converts the ferrous form of hemoglobin to ferric form. Ferric form usually does not carry oxygen. That's why the patient will land up into a condition called as methemoglobinemia. Okay, what is that thing? O-toluidine. What will happen? Okay, it will oxidize the ferrous form of hemoglobin to the ferric form. Ferric form is not carrying oxygen, whereas ferrous form usually carries oxygen. If it is not carrying oxygen, what will happen? The patient will end up into methemoglobinemia, and this methemoglobinemia can be treated with IV methylene blue. But you need to understand, EMLA should not be applied in neonates. Okay. Next, a 45-year-old obese patient is planned for elective surgery. During airway assessment, when the patient opens his mouth and protrudes his tongue, only the hard palate is visible. Which Mallampatti grade he belongs to? Class 1, 2, 3 and 4. Come on, guys, what's the answer for this? Remember, Mallampatti grading is basically done to know the ease of intubation before you give induction to the patient. Or basically in the patient usually comes to you for the PAC and you check for the airway with the help of Mallampatti classification. Okay, it will tell you the ease of intubation. If the patient is opening a mouth and you are able to see all structures clearly, hard palate, uvula and soft palate, tonsillar pillars, everything you are able to see, class 1. Okay. This patient, remember guys, Mallampatti is very easy to remember. Mallampatti class 1 is push. Mallampatti class 2 is remove the P, it becomes ush, USH. Mallampatti class 3 is what? Only SH. And Mallampatti class 4 is what? Only H. So what is Mallampatti class 1? Push. Push means what, guys? When he opens his mouth, you are able to see the tonsillar pillars. You are able to see the whole of the uvula with the tip. You are able to see the soft palate and you are able to see the hard palate. That is Mallampatti class 1. Class 2 means what? Second patient comes to you, he opens his mouth. You are able to see partial tonsillar pillars. You are able to see partial tonsillar pillars. You are able to see the uvula, but tip is not visible over here. Tip is not visible. You are able to see the soft palate. You are able to see the hard palate. That is class 2. Class 3 means what? Patient opens his mouth and you are able to see the soft palate and hard palate. Plus you are also able to see the base of uvula. Base of uvula. Uvula you are not able to see, only base you are able to see. Okay. And class 4 is what? Only hard palate is visible. And now tell me guys, which patient will be if the patient is belonging to this, if the patient is having MP4, only when he opens mouth, you are able to see only hard palate. Is he having an easy airway or difficult airway? In this case, is he having an easy or difficult? Come on, be fast. MP4 means what? Come on, be fast, guys. Is he having an easy airway or difficult airway? If you are only able to see the hard palate, that means it's having a difficult airway. For difficult airway, what you do, you keep a difficult airway trolley ready with you. Again, you have to memorize this picture also. This is the difficult airway trolley where we are keeping different forms of laryngoscope, different forms of the oral airway, nasal airway, laryngeal mask airway, everything in two sets or three sets available regarding the airway. This is the difficult airway trolley. Apart from that, you are also keeping video laryngoscope ready with you, bougie ready with you. This is called as bougie and stylet ready with you. Okay? Video laryngoscope has usually reduced the chances of difficult airway much drastically. Remember, guys, just look over here. I had performed video laryngoscopy in this patient who was having trauma to his oral cavity. And when I did video laryngoscopy, even though he was having blood in the oral cavity, still I was able to see the vocal cords clearly. That is basically a video laryngoscope for you. Okay. So over here, guys, remember Mallampati classification gives you the ease of intubation. Okay. Apart from Mallampati, there are other indicators that indicate the patient is having easy or difficult airway. That is called as Lemon classification. Lemon is nothing but look externally, evaluate the 3-3-2 rule, Mallampati score, obstruction and neck mobility. But again, among all these, the most commonly used is always the Mallampati scoring or the Mallampati classification. Okay. Next. A 60-year-old man with atrial fibrillation is scheduled for elective hernia surgery. He is on long-term anticoagulation therapy. Which drug should be sufficiently stopped in advance to reduce the perioperative bleeding risk? Basically, when a patient is on some drugs or when the patient is suffering with some disease, some drugs has to be stopped, some drugs has to be continued. He is asking which drug has to be stopped. Okay? What's the answer over here? Don't give the answer as A as aspirin. Why? Because it's more highlighted. It is just randomly highlighted. Come on, guys. What's the answer? Which drug has to be stopped? Remember, guys, all A's can be continued. The drugs that can be continued, the mnemonic to remember is all active agents always continued. The drugs that need to be stopped are basically before taking the patient to surgery, my clothes are stopped. My means patient clothes. Okay? But you need to remember my clothes are stopped. So what are the drugs which are continued before surgery? All active agents. First A stands for what? Antihypertensives can be continued except of ACE inhibitors or ARBs. They are usually stopped on the day of surgery. Next is what, guys? Anti-anginal drugs can be continued. There is no problem with anti-anginal drug. Okay? Next is what, guys? Anti-epileptic drugs can be continued. Anti-thyroid medications can be continued. And anti-cholesterol medications can be continued before surgery. Atorvastatin and all, no problem. But the drugs which are usually stopped over here is what, guys? Myclots. M stands for what, guys? Monoamine oxidase inhibitors. Has to be stopped 3 to 4 weeks before surgery. Why? Because if you continue it, it can basically, and if you give pethidine during surgery, it will react with, it will usually combine with pethidine and it will produce a severe sympathetic reaction. Okay. C stands for what? Clopidogrel. Clopidogrel has to be stopped. How many days prior surgery? 8 days prior surgery. L stands for lithium. Guys, remember all these drugs are stopped in case of elective. If it is an emergency, you have to take the patient. Okay. Lithium has to be stopped 24 to 48 hours prior surgery. O stands for oral hypoglycemic drugs has to be stopped on the day of surgery. T stands for tricyclic antidepressants, which are usually stopped 3 weeks prior surgery. H stands for heparin has to be stopped at least 6 hours prior surgery. And if the patient is on warfarin, it has to be stopped 3 to 5 days prior surgery. S stands for smoking has to be stopped at least 2 to 6 weeks prior surgery. Now, guys, remember our question was which drug has to be stopped. Metoprolol is a beta blocker, can be continued. Atorvastatin can be continued. Aspirin can be continued. Aspirin, again, 75 milligram dosage is given. That's why it can be continued. But if the patient is undergoing retinal surgery or some microvascular surgery, then aspirin also has to be stopped. But he's basically asking which drug. Clearly stopped drug is always warfarin. Warfarin has to be stopped 3 to 5 days prior surgery. Okay. ठीक है, चलो. Next. Fasting. Now, guys, regarding fasting, we are still in the pre-anesthetic checkup. That's why we are discussing over there. Fasting, patient has to be told to be in a fasting state. Why? Because if he's not fasting, there might be a chance of aspiration. Now, fasting for what food? If he is an adult who's on solid food, 8 hours of fasting is mandatory. Semi-solid food, 6 hours of fasting is mandatory. And for liquid, clear liquid without any pulp, juices without pulp, then how many hours of fasting? Whether it is adult or child, it is 2 hours of fasting. And if the child is posted for surgery, if he is on liquid like water, 2 hours of fasting. If he is on mother's milk, 4 hours of fasting. If he is on formula feed, 6 hours of fasting. But this fasting guidelines has to be maintained. But again, all of these guidelines will take only in the case of elective. If the patient is on like posted for emergency surgery, we don't go with the guidelines. We have to switch to some other different kind of things or some other different kind of techniques in anesthesia, and we have to proceed for the surgery. Okay, next. A 50-year-old patient with well-controlled hypertension with no functional limitation is posted for elective surgery. What is the ASA physical status? Now guys, when the patient comes to you for a PAC, in the PAC you look for the airway assessment, you look for investigations, you look for the drugs that need to be stopped or continue, and then fasting. Last is what you do, you give a certificate that the patient is fit to undergo anesthesia. What is that certification called as? ASA, American Society of Anesthesiologists. Now, according to this question, guys, the patient belongs to which category? 1, 2, 3, 4. The easy way to remember, I'll say that. Okay? ASA 1 means what? Patient comes to my clinic and telling, doctor, I am clearly healthy, no problem. ASA 1. Second patient comes to my clinic telling that, doctor, I am having a mild to moderate disease. यानी कि ASA class 2. Third patient comes to me telling that, doctor, I am having moderate to severe disease. That is ASA class 3. Next, fourth patient comes to me. Okay? He is telling, doctor, I am having a disease that is a risk to my life. Okay? यानी कि disease that poses a threat to his life, that then it is class 4. Then fifth patient come to me and he will be telling the doctor, I am at risk of dying. Basically, fifth patient won't come to you. You are basically called for the patient. You go in the ICU. ASA 5 and 6 are in the ICU patient. You go to the patient and he is at, basically, remember, ASA class 5 means what? He is a moribund patient. Without surgery, chances of survival are less. Having multiple comorbidities, ASA class 5. ASA class 6 means what? Brain dead patient. Okay? So over here, the patient is having well-controlled hypertension with no functional limitation. So remember, ASA depends on systemic illness. Patient free from systemic illness is ASA 1. Patient having systemic illness which is under control means what, guys? Under control. Hypertension under control means basically class 2. Smoker, socially alcoholic, hypertension under control, class 2. Class 3 means what, guys? More patient having systemic illness which is not under control, or moderate to severe kind of systemic illness, uncontrolled diabetes, alcohol dependence, BMI more than 30. Those are ASA class 3. ASA class 4 means what? Patient having life-threatening systemic illness, such as he is having a recent MI or stroke. Patient is now posted for hernia surgery, but he is telling that 1 month back I had a stroke. That is a ASA class 4 patient. ASA class 5 means moribund patient. Without surgery, the chances of survival are very less. Multiple comorbidities or having a comorbidity like ruptured abdominal aorta. A ruptured abdominal aortic aneurysm. That is ASA class 5. Okay. Class 6 means what, guys? It is brain dead patient. Again, brain dead patient, we don't do any surgery. We just harvest the organ from brain dead patient. Okay. That's regarding the ASA classification. Okay, so regarding our question, the patient was well controlled hypertension, elective surgery. So it is ASA class 2. Okay, next. 32-year-old woman undergoes cesarean section under spinal anesthesia. 5 minutes after spinal, the patient becomes hypotensive by BPA of 70/40 with bradycardia. Patient develops hypo and brady together. Okay, is it common, guys? No. Remember, after spinal anesthesia, after 5 minutes, hypotension is commonly seen. Why hypotension is commonly seen? Remember, guys, when you give spinal anesthesia, basically it is blocking the sensations below the level of umbilicus. It is producing a sympathetic block. If it is producing a sympathetic block, what will it do to the blood vessels? All the blood vessels below the level of umbilicus, they will dilate. And if the blood vessels are dilating, what will happen to the blood from the upper side of the body? It will go and fill into towards the lower side. And what will happen to the blood volume? it decreases in the upper side. If the blood volume decreases, what happens to the venous return to the heart? Decreases. What happens to the cardiac output? Decreases. And hence what happens to the BP? That also decreases. That is common. But remember, if hypo and brady together it is occurring, then you have to suspect that your spinal level has gone up. That is called as high spinal anesthesia. So in this case, high spinal anesthesia, it is characterized by two things together, hypo and brady together. Very, very, very important. Okay, hypotension and bradycardia together. It is not local anesthetic systemic toxicity. If it is local anesthetic systemic toxicity, patient would have CNS or other symptoms, not over here. Amniotic fluid embolism, pulmonary embolism, we are not going. Why? Because in the question he is mentioning after spinal related to anesthesia, something is the diagnosis. Okay, whether it should be local anesthetic toxicity or high spinal. Local anesthetic toxicity does not occur like this. Now guys, remember this thing is very common after spinal anesthesia, hypo and brady together. That's why in order to combat this, okay, in order to combat this, you have to be a very good doctor, meaning what? You have to predict beforehand that patient will develop this. If you predict this beforehand, what you will do? You will prepare a drug tray for yourself so that you are having all drugs available with you. In that drug tray, basically I prepare that emergency drug tray. In that drug tray, what are the drugs that I am keeping, guys? In the first column of the drug tray, I keep phenylephrine. Why I keep phenylephrine? Why? Because the most common complication of spinal anesthesia is what? The most common complication of spinal anesthesia is hypotension. Very, very important. Most common intra-op complication. Second complication that could occur is what? It is bradycardia. Hence I keep what, guys? Atropine. The third intra-op complication that could occur in spinal anesthesia. We are discussing about intra-op complication. The most common is hypotension. Second is bradycardia. Third is what? Shivering. The patient might have shivering, and for the shivering management I have kept pethidine with me. Okay, and the last, in the emergency drug tray, I keep a laryngoscope, ET tube and adrenaline. Now don't confuse yourself. Sir, spinal anesthesia, you are just blocking the sensations of below umbilicus. Why do you want to keep a laryngoscope, ET tube and adrenaline ready? Why? Because if at all your drug ascends upward, you have given the drug inside the CSF. Sometimes the drug can reach the central nervous system. If you have kept the patient in a head low position for a long time after spinal, then what will happen? The patient is not able to breathe and all. At that time, just to maintain the airway, you will give the patient general anesthesia with the help of laryngoscope and ET tube. But if at all the patient develops cardiac arrest in spinal, that is very rare, but it can happen if the patient develops total spinal anesthesia. You are also having a drug called as adrenaline to manage it. So remember, guys, intra-op complications we have just discussed. In the intra-op, remember, high spinal can also be seen as an intra-op complication. High spinal means what? You wanted to achieve the level of the drug. Imagine, guys, you wanted a T8 level of block, T8 block, but you have achieved a block up to the level of T6. Okay? When your desired level of block is much higher than the when your achieved level of block is much higher than the desired level. What you have achieved? T6. Your desired level was T8, but you have achieved a higher block. That is called as high spinal. High spinal is characterized by two things together, hypo and brady together. These are intra-op complication. But after surgery is done, after spinal anesthesia is given, patient is discharged. Patient is not discharged, patient is shifted to the post-op. What is the most common post-op complication of spinal anesthesia? The most common post-op complication is urinary retention, but nowadays it is not seen. Why? Because we are keeping a Foley's catheter that is preventing this. Okay. Next, headache can also be seen as a complication in spinal. Nowadays it is not seen. If headache occurs, it commonly occurs in old women or young women. Come on. If headache occurs, then it commonly occurs in old women or young women. Usually it commonly occurs in young females because young females are usually exposed to the risk of surgery due to the risk of LSCS and all. Young females headaches are common, and that headache is called as post-dural puncture headache. That is basically if you use a dura cutting needle, that could be happening. How will you manage this headache? The best management is what? You tell the patient to relax. Conservative line of management. Conservative line of management is what, guys? You tell the patient to relax, have coffee, head low position and drink water or give IV fluid. That is the best management. But it's not the definitive management. The definitive management of the headache is what? The patient is having headache due to the puncture inside the dura. From that dura puncture, there is constant leak of CSF. So you need to just close the puncture. So definitive management is what, guys? It is the epidural blood patch. Epidural blood patch. Okay. The cranial nerve commonly damaged in spinal anesthesia is again the 6th cranial nerve. Why? Because it's having a long course. 6th cranial nerve palsy could be seen. Next. A 35-year-old man is undergoing spinal anesthesia for inguinal hernia surgery. Okay. So anyways, while inserting the needle, the anesthetist feels 2 pops before clear fluid is seen at the hub of the needle. Which of the following best describes the sequence of structures pierced by spinal needle? Come on, guys. As your needle is passing through the skin, what is the layers pierced in spinal? If someone asks you, you have to tell what are the layers of layers pierced by your needle. If someone asks, you have to tell, some say spinal instigates lethargy during anesthesia. Some say, yani ke the first is what, guys? Skin. Okay? The mnemonic is, some say spinal instigates lethargy. Okay? So look over here. Some S stands for skin. Next, subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum. Just look over here, guys. While I pierce ligamentum flavum, suddenly you will feel that you have pierced ligamentum flavum. Why? Because ligamentum flavum is it's basically a hardest or the toughest ligament. And once you pierce ligamentum flavum, you will feel a pop. And once ligamentum flavum is pierced, then there will be what? Dura. Once you puncture the dura, there will be what, guys? Arachnoid membrane. Okay? Arachnoid membrane. And remember, once you puncture the arachnoid, there will be subarachnoid space that will have CSF. So the order of layers that are pierced are what? First is skin. Okay? Next, subcutaneous tissue. Next, supraspinous ligament. Next, interspinous ligament. Next, ligamentum flavum. Ligamentum flavum. Ligamentum flavum is the toughest ligament. On piercing is, you will see a snap or sudden loss of resistance. Okay, that is very, very important. Second pop you will feel once the dura is punctured. Okay. Next, once the dura is punctured, you will be in the arachnoid, and once you puncture the arachnoid, you will be in the subarachnoid space that has the CSF. So last layer to be pierced is the arachnoid. Again, that was asked as an MCQ. Last layer to be pierced in spinal is what, guys? The arachnoid. This is regarding the layers that are pierced by your needle in spinal anesthesia. Okay. Now, remember, guys, this was regarding spinal. Epidural anesthesia is given for what surgeries? Epidural anesthesia can be given for surgeries done below the level of umbilicus for a longer duration. Apart from that, epidural can also be given for any lymph node dissection at the cervical level. Cervical lymph node dissection, you can give epidural. Cervical radiculopathies, you can give epidural. Now, you must be wondering, sir just not thought epidural is given usually for below umbilicus. Why is he telling epidural can be given for lymph node dissection, cervical lymph node dissection? It can be given. But will you place an epidural at the lumbar intervertebral space and will you tell your drug to act at the cervical? No. If you want to give epidural anesthesia for cervical lymph node dissection, you have to place cervical epidural. Okay, so remember, epidural anesthesia, the needle that we use is what, guys? It is 2-Hoy's epidural needle, very easy to identify. It will have 1 centimeter of light and dark band on it. It is 9 to 10 centimeters needle. It is usually given for below umbilicus long duration surgeries. Apart from that, it can be placed remember, you can place cervical epidural, which is usually used for neck radiculopathies or lymph node dissection. Thoracic epidural can also be used. Recently, it came as a question. Patient having a road traffic accident. He had a rib fracture from 3rd to 8th rib. What is the best way to manage his pain? The answer was placing a thoracic epidural. Okay? For thoracotomy pain or for sternotomy pain, you can give a thoracic epidural. Lumbar epidural is usually given for below umbilicus long duration, or you can also use lumbar epidural for labor analgesia. That is commonly used, guys, for labor analgesia. Okay. Next, there is caudal anesthesia. Caudal anesthesia meaning what? You are giving caudal epidural anesthesia usually for usually for children who are posted for anorectal or perineal surgeries. Okay, what is the space where you are inserting the needle? At the level of sacral hiatus. And what is the last layer to be pierced in caudal anesthesia? It is the sacrococcygeal ligament. Sacrococcygeal ligament, that is last layer to be pierced in caudal anesthesia. Now, what is the contraindications of spinal anesthesia? Remember guys, in some conditions spinal should be contraindicated. What conditions? I'll tell you. If the patient is having shock, spinal is contraindicated. Why? Because the most common complication of spinal anesthesia is what? The most common complication is hypotension. So in shock it is contraindicated. In raised intracranial pressure it is contraindicated. Why? Because if you give spinal anesthesia and raised intracranial pressure, they will be jetting out of CSF and all. Okay. Next, if the patient is having fixed cardiac output lesion, spinal is contraindicated. Fixed cardiac output lesion, they cannot withstand any hypotension, severe mitral stenosis. You cannot give spinal anesthesia. If the patient is having local site infection at the level of insertion of spinal needle, if the patient is having infection at that site, don't give spinal anesthesia. Apart from that, spinal is also contraindicated if the patient is having refusal. Yani if the patient refuses, spinal is contraindicated. Okay. Next, a trauma patient with severe hypoxia requires maximum oxygen delivery in the emergency room, which is the best one. Now guys, remember, in the emergency you have to give maximum oxygen. You are having these devices with you: nasal prawns, simple face mask, venturi mask, non-breathing, which will deliver a high oxygen. If he is in emergency room, okay, first what will I do? I'm not solving this MCQ. If he's in emergency room, he's in hypoxia, not severe hypoxia, just some hypoxia. The first device I'll go is what? I'll go with nasal prawns. Nasal prawns, when I tell the nurse to apply nasal prawns, nurse will be asking, how many liters of oxygen should I give? You should tell nasal prawns will give oxygen up to 1 to 6 liters. That will in turn deliver the FiO2 of 25 to 45%. 25 to 45%. Okay. If the patient is not improving, what you will tell? Okay, remove the nasal prawns and go for a simple face mask. He'll ask, how much liters of oxygen should I give? You should tell 6 to 10 liters of oxygen it can give, and which will in turn deliver an FiO2 of how much? 35 to 65%. If still not improving, then you go for what? Then you go for other mask, that is called as NRBM. Venturi mask, again guys, remember, venturi mask 2 to 15 liters of oxygen, but it is giving a fixed FiO2 of 24 to 60%. Okay. Non-rebreathing mask can give an oxygen of 10 to 15 liters. That in turn gives an FiO2 up to 95%. So what's your answer over here, guys? Maximum that could be given over here is through the non-rebreathing mask. So I told you, nasal prawns is there, simple face mask is there, NRBM is there, venturi is there, and high flow nasal cannula is there. There have been questions asking you about the flow rates and the FiO2 being delivered. So with nasal cannula, always remember 1 to 6 liters, which delivers an FiO2 of 25 to 45%. And remember guys, each 1 liter increase in the oxygen flow rate will give you, like if you increase 1 liter of flow rate, how much of FiO2 will be increased? 4% of FiO2 will be increased. Okay. Face mask 6 to 10 liters of oxygen, that will deliver 35 to 65% of FiO2. NRBM 10 to 15 liters of oxygen, that will deliver 95% of FiO2. Venturi mask 2 to 15 liters of the flow rate, that will deliver an oxygen of 24 to 60%. High flow nasal cannula, very, it gives a high flow rate, guys. Okay, how much? 40 to 60 liters of oxygen per minute. That will deliver an FiO2 of 100%. High flow nasal cannula. Okay, so the answer, you got it over there, right? Then there is what, guys? AMBU. AMBU is nothing but what? Artificial manual breathing unit. Okay. Mostly when a patient is shifted from emergency, or the patient in the emergency you are not able to intubate, you can just put an AMBU bag and you can ventilate the patient. In the AMBU there is a pressure relieving valve, okay, and there is one more valve called as Rubin valve, that is usually preventing that is usually called as a unidirectional valve. Okay. The pressure relieving valve is usually seen in the pediatric AMBU that relieves the pressure at 30 to 40 centimeters of water, and AMBU delivers 100% of oxygen. Okay. Next, a patient with moderate hypoxemia is receiving oxygen through the nasal cannula at 3 liters per minute. What is the approximate FiO2 delivered? Come on, guys. Who will answer this? Who will answer? Guys, remember I told you 3 liters per minute. 1 liter gives you 4% increase of FiO2. 3 liters means 3 into 4, that is 12%. Okay? 12% plus you have to add additional atmospheric oxygen, which is usually 21%. So 21 plus 12 gives you approximate value of 33%. So what's your answer over here? What's your answer over here? 32%. It is coming 33 near to it. Is it clear? Okay. But the rule is what? 1 liter increase gives you 4% increase. Next, a patient with ARDS is ventilated. Which strategy improves the patient's survival? ARDS is adult respiratory distress syndrome. Already the alveoli are totally in a very bad state, collapsed state. Lung is in a very bad state. Which ventilation strategy you will go for? If you go with a high tidal volume strategy, what will it do? Already the lung is in a bad state. It cannot take a high tidal volume, and what will happen? Basically, you just remember, guys, alveoli are very fragile, and you give a high tidal volume, alveoli are gone. So remember, high tidal volume is never given. Okay. 0 PEEP. PEEP is what, guys? Positive end expiratory pressure. This is also never given in ARDS. You always go with like medium to higher level of PEEP, not 0 PEEP. PEEP is always given in ARDS to improve the oxygenation. You know, guys, basically in ARDS, the alveoli, the lung is in a very bad state. You usually give PEEP. PEEP is usually a soldier that goes to the lungs. It will help the lungs to recruit new alveoli, helps in oxygenation. So you need to go for a high PEEP. Okay? Can you go for low tidal volume ventilation? Yes. So for ARDS, you have to go for low tidal volume ventilation. High respiratory rate alone won't work. Low tidal volume ventilation should be always given in ARDS. So that's the correct answer. Okay. Now, guys, remember we are discussing about what? We are discussing about something about ventilators. Remember, when a patient is coming to you with hypoxia kind of state where his saturation is falling, first you go with normal oxygen mask and the simple nasal cannula or face mask or other devices. If still his saturation is not improving, you connect a ventilator. In ventilator, there are two types. One is the non-invasive one, other is the invasive one. Non-invasive means you're applying a mask and then ventilating the gases into the lungs of the patient. That is non-invasive. Invasive means you are putting a tube and then giving the gases to the patient. Okay? Now, in non-invasive, remember, guys, there are again two types. But before proceeding towards a non-invasive ventilator, make sure one or two things very clear. Most importantly, what, guys, the main prerequisite for non-invasive ventilation is patient should be conscious. Why? Because if the patient is unconscious and you put a non-invasive ventilator, he will aspirate. Okay? And second thing is what? Patient should be empty stomach. Empty stomach, basically, if he is conscious, if you just fulfill this criteria, then you can go for non-invasive. Conscious patient means if he is full stomach also, he will basically with the help of epiglottic reflex, no risk of aspiration, but he has to be conscious, then only non-invasive ventilation. There are two modes, CPAP and BiPAP. CPAP is continuous positive airway pressure. BiPAP is it usually used two pressure, a higher inspiratory and a lower expiratory pressure. Usually these two modes of ventilators are usually used for COPD cases. If the patient is having a mild COPD, you can go for CPAP. But if severe COPD is there, you go for BiPAP. Okay, so that's regarding the non-invasive ventilation. If the non-invasive ventilator, the patient's GCS is going low, saturation is going low, then you need to take an intubation consent and go for invasive ventilation. In invasive ventilation, there are many modes that we need to remember. Okay, the first mode is what? In invasive ventilation, the first mode is called as CMV mode. The second mode is called as ACMV mode. The third mode is called as spontaneous mode. Now, guys, remember, we are discussing about the invasive ventilator. The rule for using an invasive ventilator is what? In that you need to remember, either you can control the tidal volume or either you can control the pressure. That is the rule. Okay? But there is one mode of ventilator that usually controls both the things together. What is that mode, guys? that is CMV mode. CMV mode is a mode of ventilator, or basically if the patient is having a road traffic accident, initially he's not at all breathing, he is in a vegetative state and he's not at all using his lungs. In that case, you go towards the soldier mode for the ventilator, that is CMV. CMV will tell what? He will tell, I will control the tidal volume, I will deliver the pressure, you don't take any load. He will tell to the doctor, you don't take any load. But the CMV mode will tell the doctor what? At the same time, I don't want your patient to have any efforts. He will tell the doctor to sedate the patient heavily. The patient will be sedated heavily in this mode, and as the patient is heavily sedated in this mode, what will happen, guys? After some time the patient becomes lazy, patient becomes dependent on the ventilator, and due to this dependency of ventilator, the patient is not using his respiratory muscles for breathing and all. Patient develops what? Patient develops muscle atrophy. The most common side effect of this mode is what, guys? Muscle atrophy. So I told you guys two important things which can be controlled is what? Either tidal volume or the pressure. Now, after CMV, if the patient is improving on CMV, then we need to go for a step down mode of CMV that is called as ACMV. In the ACMV, there is volume control mode or there is pressure control mode. If you as the anesthetist or the physician, you are setting the volume, then it is called as volume control mode. Why? Because remember, if you are setting the tidal volume, ventilator will take responsibility of the pressure. If you are setting the pressure, ventilator takes the responsibility of generating the tidal volume. Only one of the two things you can set. If you are setting the volume, it is tidal volume. If you are setting the pressure, it is pressure control mode. Okay. Now look over here, guys. In CMV mode, I told you what is the controlled variable in CMV mode. There is no control variable. Ventilator is controlling both tidal volume as well as the pressure. Is the ventilator allowing the patient breathe or any trigger breathe? No. How is the sedation in CMV mode? Patient requires heavy sedation. And what is the side effect of CMV mode? The patient will have atrophy of the muscles. Okay. ACMV, volume control. In volume control, what is the control variable which I can set? It is always the tidal volume. Is trigger breathing allowed? Yes. In between, you will allow some trigger breathing. How is the sedation? When compared to CMV, as you are allowing trigger breathing, you will keep the patient sedation moderate. In volume control, as I am setting the tidal volume 6 to 8 ml per kg, ventilator will generate the pressure. As ventilator is generating the pressure, sometimes the pressure generated would be high, sometimes it might be low, but most of the times the pressure is high only. The risk of barotrauma is high in this mode of ventilator. The risk of barotrauma is high in volume control mode of ventilator. Pressure control means, what is the control variable in pressure? I am controlling the pressure. I am deciding the pressure. Is trigger breathing allowed? Yes. How is the sedation? Moderate. What is the side effect of pressure control? In pressure control, remember guys, we are setting a pressure, ventilator decides how much volume should be given to the patient, and most of the time ventilator is usually underestimating and giving a low volume. If he is giving a low volume, what will happen to the patient? Patient would be hypoventilated. If the patient is hypoventilated, what will happen to the pH of the patient? Patient develops respiratory acidosis. Okay. Pressure control mode is usually used in ARDS as the compliance of the lung is very low. As the patient is improving, then you can go on ACMV, you can go for spontaneous. Spontaneous modes means these are SIMV mode and pressure support mode. Okay. These are usually the weaning modes of ventilator. When we use this mode, when the patient is improving from the primary pathology and his oxygen saturation is improving, respiratory rate is improving and all, then you go for SIMV or pressure support mode. These are only giving some support to the patient. Okay? Imagine guys, this is the patient breath. Okay, this is the patient breath in SIMV. This is the patient breath in SIMV. Right? As after 2 breaths, if the patient is not breathing, then ventilator will give a high tidal volume. It will generate a high tidal volume and it gives support to the patient. Then again patient breath. Then again patient breath. So every 2 to 3 breaths, the ventilator is supporting the patient. But again, due to this also, as there is a asynchrony between the patient breath and the ventilator breath, sometimes there might be a chance of hypo or hyperventilation. There might be chances of both hypo or hyperventilation. If it goes to hypoventilation, patient develops respiratory acidosis, and if the patient develops hyperventilation, carbon dioxide washout होने की वजह से patient will have respiratory alkalosis. It can happen. बिल्कुल बिल्कुल ठीक है. That's regarding what, guys? That's regarding the ventilators. Now guys, tell me which mode of ventilator will be telling that कभी कभी लगता है अपन ही भगवान है. Who will be telling? Which mode of ventilator will tell this? The one who is controlling all two things together. Come on. What is that mode, guys? Very good, very good. CMV mode of ventilator. CMV mode of ventilator. Okay. Now, guys, just look over here. A 45-year-old man with severe pneumonia is admitted to the ICU with hypoxemic respiratory failure. He is intubated and placed on volume controlled ventilation. His current settings are: we have set the tidal volume of 6 ml, respiratory rate of 20, FiO2 of 0.8 and PEEP of 5. But still ABG shows persistent hypoxemia. Still his oxygen is not improving. What is the next best step? Okay? Will you increase the tidal volume to improve oxygenation? Increasing tidal volume never helps, guys. A patient is having pneumonia, already lungs are in a bad state. You don't overinflate the lungs and you don't damage the lungs. Okay? So don't increase the tidal volume. Next is what? Decrease the respiratory rate. If you decrease the respiratory rate, carbon dioxide will accumulate. So you cannot do it. Switch to pressure support. How will you switch to the pressure support? He's not improving on this. Pressure support is what? When the patient is improving on this mode of ventilator, then you have to go for pressure support. He's not improving his ab, so you cannot go for it. What you can do, remember, if he's having hypoxemia, add PEEP to it. What is PEEP, guys? PEEP is nothing but positive end expiratory pressure. PEEP is a soldier. When you call, when do you call PEEP, guys? When the alveoli are being collapsed. When you add PEEP, PEEP will go into the lungs and it will tell, I have recruited more alveoli so that your oxygenation improves. Okay. So you have to increase the PEEP gradually. But remember, there are some side effects with the PEEP. So PEEP is recruiting alveoli to improve the oxygenation. PEEP is positive end expiratory pressure. It improves oxygenation. It prevents atelectasis. It decreases the work of breathing. Okay. And usually this is used for ARDS and pulmonary edema. But the side effect of PEEP is what? When you are adding PEEP, the patient will have a high intrathoracic pressure. Due to high intrathoracic pressure, the venous return decreases. The cardiac output decreases, due to which the patient will have hypotension. So PEEP is contraindicated if the patient is in shock-like condition. Never use PEEP. PEEP is also contraindicated if the patient is having high intracranial pressure. Now your question should be, why sir, why PEEP is contraindicated in high intracranial pressure? When I give PEEP for a longer period of time, it will decrease the cerebral venous drainage that can increase the intracranial pressure. So PEEP should be reduced. So in these two conditions, okay, PEEP is contraindicated in shock as well as high intracranial pressure. Next. A patient with head injury is on mechanical ventilator. His target PaCO2 is 30 to 35. For ICP control, which ventilator adjustment is most appropriate? What adjustment you need to do in a ventilator if you want to control the intracranial pressure? A, B, C, D. Come on, guys. What's the answer? Basically, you need to understand one small thing, guys. Okay? In any condition, if carbon dioxide is high, if the PaCO2 is high, then intracranial pressure will be high. My aim should be, I should lower down the carbon dioxide. Can you lower down the carbon dioxide by increasing the FiO2? No. Increasing the FiO2 just improves in oxygenation. But you cannot lower the carbon dioxide with this rate. Okay? Can you increase the PEEP and lower the carbon dioxide? That is also no. If you increase the PEEP, I told you guys, increase positive, increase in PEEP will cause what? It will basically cause decrease in the cerebral venous drainage, which can lead to increase in intracranial pressure. Okay, now you are left out with increasing the respiratory rate or decreasing the respiratory rate. If you increase the respiratory rate, what will happen, guys? Carbon dioxide gets washed off. Yani there is cerebral vasodilation that leads to decrease in the cerebral blood flow and decrease in the intracranial pressure. Okay, but if you decrease the respiratory rate, again carbon dioxide gets accumulated and ICP will be increased. So you need to understand, guys, intracranial pressure is directly related to the carbon dioxide. Anything that is done to reduce carbon dioxide will usually help in reducing the intracranial pressure. Next, guys, we need to understand this. What is the normal values of, while setting the ventilator, what is the normal values? The respiratory rate that we keep is how much, guys? 12 to 18. But in case if the patient is having respiratory acidosis where his PCO2 levels or carbon dioxide levels are high, in that case what you can do, you can increase the respiratory rate. Any values, 20, 24, 30 also you can take it to wash out the carbon dioxide. Tidal volume, in normal conditions, tidal volume, how much you should keep? 6 to 8 ml per kg. But in case of ARDS where lungs are already in a very bad state, you do not want to over distend the lungs or the alveoli. What you need to do in ARDS, you need to go for low tidal volume ventilation. Low tidal volume ventilation in ARDS. Next, FiO2, how much you should keep? 21 to 100% of FiO2 has to be kept. Okay. PEEP, how should you keep? 5 to 24, maximum 24. PEEP is usually helping to improve what? Oxygenation of the patient. Okay. P plateau pressure should be less than 25. There is one more pressure called as P peak. It should be less than 30. Remember, if there is problem, if the P peak pressure is high, the problem is there is some obstruction in the passage of the gases. If P peak is high, if P plateau is high, there is problem with the compliance. Okay. So anyways, I is to E ratio should be how much? Inspiratory to expiratory ratio is 1 inspiration to 2 expiration. But in case of ARDS, you usually go for inverse ratio ventilation. That is, you keep inspiratory to expiratory ratio 3:1. Or you can also go for prone position ventilation for ARDS. Okay. Next. All right. A hypotensive trauma patient requires emergency intubation. Which induction agent is safest? Come on, guys. Propofol, thiopentone, ethomidate, or midazolam. Guys, remember, if the patient is in hypotension, we are assuming a patient is having a BP of 70/40. I need to induce the patient unconscious. What should I do, guys? Which IV induction agent should I give? Ideally, the best IV induction agent for this patient is ketamine, but ketamine is not given in the option. Why ketamine is best? Why? Because ketamine increases the BP. Remember, propofol you cannot give. Why? Because propofol causes hypotension and bradycardia. Thiopentone causes hypotension and thiode stands with T and tachycardia stands with T. So it cannot be given. Both cannot be given. You are left out with midazolam. Midazolam again causes hypotension. So we are not giving it. Ethomidate can be given. Ideally, the best agent is ketamine, but ethomidate can be given. Why? Because ethomidate is a cardiostable IV induction agent. It does not decrease the BP. It maintains the BP in the same direction. Okay. Now, as we are discussing about the IV induction agents are usually used to make the patient unconscious. For general anesthesia, you use this IV induction agents. There are two types of IV induction agent, non-opioid and opioid. In non-opioid, you are having benzodiazepines and other agents. Okay. Now remember, guys, whether in what are the non-opioid agents? Thiopentone, propofol, ethomidate, and ketamine. Thiopentone, propofol, ethomidate, they are usually working or they are usually acting through the GABA receptors or the GABA channels. Benzodiazepines or barbiturates, they are usually acting on the GABA channels. But ketamine and nitrous, there are some IV induction agent called as ketamine. Apart from ketamine, xenon and nitrous, those are inhalational induction. Just for your remembrance that there are some agents that acts on NMDA receptor to make the patient unconscious. That is ketamine. With ketamine, xenon and nitrous also acts on it. Okay. Apart from that, we can also go with opioid induction. Opioid means you can give a high dose of fentanyl, high dose of sufentanil. Why do you go for opioid induction? In which patient you go for opioid induction? In patients whose ejection fraction is low, you go for opioid induction. Okay, so anyways guys, we are discussing about the IV induction agents. Now our question, ethomidate was asked, right? So what is ethomidate? Ethomidate is the most cardiostable IV induction agent. Cardiostable meaning what? Neither decreases BP, neither increases BP. Okay, yeah, but remember it comes with a side effect. What side effect? When you give ethomidate for a long-term infusion, patient will have adrenal suppression. Very, very important. So long-term infusions of ethomidate is not used. If you want to use long-term infusion in ICU, you are having dexmedetomidine, you are having other drugs available with you. Okay? Next. There is one more IV induction agent called as methotrexate. Methotrexate is usually used for electroconvulsive therapy. Next. A patient is in ICU on prolonged infusion for sedation, develops metabolic acidosis, rhabdomyolysis, cardiac failure. Which drug is commonly responsible or mostly responsible? Guys, remember, when a patient is in ICU for a long-term infusion, in a long-term sedation, for long-term sedation, don't give any of the drugs, propofol or ethomidate or ketamine. No. For long-term ICU sedation, we are using dexmedetomidine. Okay? We are using fentanyl. Okay? But we are never using these drugs, guys. We are never using these drugs. Why? Because remember, if you use one drug as a long-term infusion, it can land up into propofol infusion syndrome. As you know, what is the drug that I'm talking about? Propofol. When you give propofol for more than 48 hours, especially in children, they will land up into this syndrome called as propofol infusion syndrome. Now, as we are discussing about propofol, we have to discuss a few points of propofol. How does it look like? Propofol looks like a milky white solution. Okay? So, propofol is made up of what? It is made up of egg lecithin, glycerol, and soy. Okay, egg lecithin is used as an emulsifying agent in propofol. The one more property of propofol is once you open the vial of propofol, it should be used within 6 hours. Otherwise, it gets contaminated. As we are giving the drug to the patient, propofol to the patient, it usually causes pain. It is the most painful IV induction agent. Apart from propofol, other agents that are painful are ethomidate and thiopentone are also painful. Ethomidate and thio are also painful IV induction agent. Okay. Now, regarding propofol, you always need to remember propofol is used as an IV induction agent of choice for what surgeries? You have to remember it can be used as an IV induction agent of choice for almost all surgeries. But you need to remember it is IV induction agent of choice for daycare surgery. Imagine guys, a patient comes to me for daycare surgery. He came to me for a PAC. He is asking me, sir, as it is a daycare surgery, will you put an LMA or will you put an endotracheal tube? What you will do? You will tell, I will put an LMA. So basically, propofol is an IV induction agent of choice for daycare surgery as well as LMA insertion. Next, he will ask, doctor, as it is a daycare surgery, I have read in the internet that some inhalational agents are also given. Will you give inhalational agents or will you go for only IV induction and only you will maintain anesthesia on IV? You will tell, I will give IV induction agents and I will maintain the whole anesthesia through the IV route only. So that is called as TIVA. TIVA is nothing but total intravenous anesthesia. So propofol is used as an IV induction agent of TIVA. Okay? Now he'll ask you, doctor, I have read somewhere that some drugs will cause nausea, vomiting, some drugs will cause allergy and all. You tell him, I'll give you propofol as an IV induction. Why? Because it's having what property? Anti-emetic property, anti-pruritic property. Okay? Now again he'll tell, doctor, I have read somewhere that some of the IV induction agent that you will give, that you will use will cause some this thing, liver disorder, or can cause a condition called as malignant hyperthermia. Okay? Or can lead to acute intermittent porphyria. You tell him, I will give you an IV induction agent for your daycare surgery which is free from side effects of malignant hyperthermia. It can be safely given in liver disorders and It is free from side effect of acute intermittent porphyria. So basically, guys, if you remember daycare surgery, you will remember all these things. Propofol is used as an IV induction agent of choice for daycare surgery, LMA, TIVA, antiemetic, antipruritic, malignant hypothermia, liver disorder, and acute intermittent porphyria. Okay. Next. A head injury patient is given an IV induction agent that reduces intracranial pressure but has no analgesic property. Which drug was used? Come on, guys. Head injury patient, you have given the drug that, which is the IV induction agent that could be used in head injury. Come on. Remember, ketamine should never be given in head injury. If you give ketamine in head injury, ketamine does kit with the CNS. It increases the ICP. It cannot be given. The only IV induction agent of choice that can be safely given in head injury is what? Thiopentone. And thiopentone does not have any analgesic property. Instead, you have to give what? You have to give with thiopentone, you have to give some lignocaine or something. Ketamine, pat se headshot. Okay. Sodium thiopentone. As we are discussing about sodium thiopentone is regarded as an ultra short acting barbiturate. Why it is regarded as an ultra short acting barbiturate, guys? Why? Because due to its rapid redistribution, it gets redistributed into the adipose tissue and the muscle very easily. That's why it is regarded as ultra short acting barbiturate. Okay. Now, it has anti-thyroid property. Apart from that, it is prepared in almost all solution except of Ringer's lactate. Why Ringer's lactate? You don't prepare it. Why? Because it can form what? It can form crystals. Okay, that's regarding sodium thiopentone introduction. One more important point of sodium thiopentone that we need to remember is what is the effect of sodium thiopentone on various systems. When we are talking about various systems, we are talking about the central nervous system, respiratory system, cardiovascular system, muscular system, and the analgesia. So you need to remember one line so that you can remember all points of sodium thiopentone. What is that one line? Sodium thiopentone is the best friend of central nervous system, enemy of all systems. Best friend of CNS. Remember, guys, I am telling it's not just friend, best friend. When I am telling best friend, it will have good effects on the CNS. So if it is having good effects, can it be given for CNS problems? Yes. Okay. So it can be given for, it's a best friend of CNS, but enemy of all other systems. As it is a best friend of CNS, it can be used as a IV induction agent of choice for head injury and neurosurgery. It can be used as an IV induction agent of choice for a patient who is having epilepsy. Why? Because it's having anti-epileptic property. It can be used as an IV induction agent for narcoanalysis, truth test. But remember why it can be used? Why? Because it's a best friend of CNS. It is the enemy of other system. Enemy of other system means we will discuss only about respiratory and cardiovascular. As it is an enemy of respiratory system, what will it do to the respiratory system? Enemy means will it be used as an IV induction agent of choice, or will it have contraindications? It will have contraindications. So called contraindication, guys, as it is an enemy of respiratory system, it is contraindicated in bronchial asthma. As it's an enemy of cardiovascular system, it is contraindicated in shock and ischemic heart disease. One line, all MCQs covered. Thiopentone is the best friend of central nervous system, enemy of other systems. Okay. Next, guys. A patient develops hallucinations and delirium after anesthesia. Which receptor is primarily responsible for the drug which is being used? Come on, guys. Patient is developing hallucinations after anesthesia. Hallucinations after anesthesia, only one IV induction agent. In the IV, sevoflurane also causes hallucinations, but in the IV induction agent, only one comes to my mind. What is that, guys? It is ketamine. Ketamine causes hallucinations. While recovering from the effect of ketamine, patient will tell weird things. He's basically hallucinating. So why it occurs, guys? What is the response? Why it is occurring? Why? Because this ketamine blocks the NMDA receptors, leading to dissociative anesthesia. Now, as we are discussing about ketamine, remember, guys, ketamine, when you give to the patient, it will augment opioid analgesia and will reduce the, when you give ketamine, It will augment the opioid analgesia as well as it reduces the opioid tolerance. But what is ketamine? It's a complete anesthetic agent. It is a phencyclidine derivative and NMDA receptor blocker. Phencyclidine derivative and NMDA receptor blocker. Nowadays we are having a new drug of ketamine which is called as S-ketamine. Okay. Uses all his abusive vocabulary. What abusive vocabulary I have used? A patient might have used after ketamine. Okay. So, S-ketamine is a psychoactive drug which usually works as a rapid acting antidepressant. Okay. Now, guys, remember when you are studying about ketamine, what you need to remember is ketamine effect on various systems. It is totally opposite of thiopentone. Thiopentone was best friend of CNS, enemy of others. Ketamine will be what, guys? Ketamine is the worst enemy of CNS and best friend of other systems. Best friend of other systems and worst enemy of CNS. Okay? As it is the best friend of other systems, what will it do to the respiratory system? Ketamine causes bronchodilation, hence it's the IV induction agent of choice for bronchial asthma. Ketamine usually increases the BP and pulse rate, so it is a IV induction agent of choice of patient who is in shock or cyanotic heart disease but contraindicated in ischemic heart disease. Okay? Ketamine increases the muscle tone also. Why ketamine is regarded as the worst enemy of CNS? Why? Because it will do some problems to the CNS. It increases the intracranial pressure, hence contraindicated in head injury and neurosurgery. It increases the intraocular pressure, hence contraindicated in glaucoma. Next, ketamine causes epilepsy, hence contraindicated in epileptic patients. Ketamine next causes hallucinations, hence contraindicated in schizophrenia. If at all some hallucinations are seen with ketamine, caused by ketamine, then it can be easily managed by giving midazolam to the patient. Hallucination caused by ketamine can be managed by midazolam. Okay? Right. Next, a burn patient is given succinylcholine for intubation. He develops cardiac arrest. What is the cause of it? Come on. A burn patient is given succinylcholine. What would have caused cardiac arrest? Succinylcholine basically will cause muscle relaxation. It's a muscle relaxant, depolarizing muscle relaxant. Okay? But can it cause cardiac arrest? Yes. Why? Because remember, the patient is having burns. Burn patient is already hyperkalemic. If that hyperkalemic patient receives succinylcholine as a muscle relaxant, normally the side effect of succinylcholine is it can cause hyperkalemia. But already the patient is hyperkalemic. It will worsen the hyperkalemia, leading to what, guys? Arrhythmias that can cause cardiac arrest. So what's the cause of cardiac arrest over here? Hyperkalemia. Now discussing something about the succinylcholine. Succinylcholine is a depolarizing muscle relaxant which is regarded as the shortest as well as the fastest acting muscle relaxant. Why it is regarded as the shortest acting? Why? Because it works for 3 to 8 minutes. Why it is regarded as the fastest acting? Why? Because the onset is 30 to 45 seconds, the patient muscles will be relaxed. Where is the metabolism? It is metabolized in the plasma by plasma pseudocholinesterase. Okay. Now there is one condition called as choline apnea. Guys, just remember, I told you choline should act only for 3 to 8 minutes. After 8 minutes, the patient should recover from the effect of choline. Choline will relax the muscle, and after 8 minutes, he has to breathe spontaneously. He has to move. That means he has recovered from the effect of choline. But there are some patients in which choline, after giving choline, after 20 or 30 minutes also, patient still is not breathing spontaneously. Such a patient not breathing spontaneously after 20 to 30 minutes after choline administration will land up into a condition called as choline apnea. That usually occurs when there is deficiency of the enzyme that usually metabolizes choline. What is that, guys? Deficiency of pseudocholinesterase condition. In case of deficiency of pseudocholinesterase, you will see choline apnea. How will you diagnose choline apnea? For diagnosing choline apnea, there is a test called as Dybuque number test. Guys, remember Dibucane? Dibucane was the longest acting local anesthetic but most toxic. We are not using that for anesthesia purpose. Dibucane is usually used for detecting atypical pseudocholinesterase. Okay, and if at all the patient lands up into choline apnea, no need to worry. You have already intubated the patient. Na? The main management of choline apnea is what? You give positive pressure ventilation to the patient. Okay, next, what is the effect of side effect of choline? Remember guys, when you give choline to the patient, initially the patient will have violent muscle contraction and then the muscle will become relaxed. Due to that, the most common side effect of choline that the patient will land up, it's what guys? Patient will have muscle soreness. The second common side effect is hyperkalemia. The patient's potassium levels would be high. Apart from that, malignant hypothermia can also be seen as a side effect of choline that we will discuss later. Next, a patient with renal failure requires muscle relaxation. Which drug is the safest? ABCD. Patient is having renal failure. Which muscle relaxant should be given? Remember guys, in muscle relaxant, we are having depolarizing and non-depolarizing. Depolarizing, just now we have covered, that is succinylcholine. In non-depolarizing, you are having benzyl isoquinoline and steroidal. Okay? We'll come to this question later. In benzyl isoquinoline, they are the drugs which are ending with curium. Steroidal are ending with curoniums. Remember, benzyl isoquinoline examples are atra, curium, cisatra, curium, meva, curium, doxa, curium. Steroidal, what are the examples? Pan, curonium, rock, curonium, and vec, curoniums. Okay, now guys, remember, when the muscle relaxant was introduced, the first introduced muscle relaxant was D-tuberculare, but it was having some side effect. Guys, everyone just look over here. You will get this story of muscle relaxant. Just look over here. Initially, we were having IV induction agents to make the patient unconscious, but we did not have muscle relaxant. There was a guy at that time whose name was Harold Griffith. He told, I will give a drug that will cause muscle relaxation. And he gave a drug called as D-tuberculare to the patient. And the patient muscles was relaxed. Surgeon was happy that patient muscles are relaxed. But at the same time on the monitor, like at that time, there were no monitors also. They were trying to feel the pulse. They're trying to feel the BP. The BP and pulse was getting very low. That's why D-tuberculare, even though it was used as the first introduced muscle relaxant, we are not using it. They told Harold Griffith to come up with some other muscle relaxant, but he did not prepare any other muscle relaxant. At that time, there was some anesthetist group. What they did research on a drug, and they came with the next muscle relaxant, which was called as atracurium, which belonged to benzyl isoquinoline. So this atracurium, when it came into the market, it became widely familiar and popular. Why? Because atracurium was a drug which was not metabolized in the liver nor in the kidney, nor it was excreted through the kidney. It was undergoing a magical metabolism called as Hoffman degradation or Hoffman elimination. Okay? But soon after some time, they came to know there were two side effects of atracurium. What were the two side effects associated with atracurium? Atracurium was causing histamine release, and when you were giving atracurium for a long-term infusion, it was causing formation of laudanosine. Laudanosine is nothing but what, guys? It was a compound that was leading the patient to seizures. Due to these two side effects of atracurium, again the surgeons told the anesthetist, we are not using atra. Some better drug is there in atra. Some better drug could be introduced better than atra. So then the anesthetist, they got offended. Why? Because atra was a very good drug, but still they had to come up with the other drug. Why? Because two side effects were there. Then came the second drug after that is cisatracurium. Cisatracurium is also undergoing the same metabolism, Hoffman degradation, but it is having less side effects. Then came the shortest acting muscle relaxant, which is called as mevacurium. Okay, shortest acting non-depolarizing muscle relaxant. Then came the longest acting muscle relaxant, which was called as what? Doxacurium. But doxacurium was having side effects, much toxic side effects. Then came the second longest acting, which was in the steroidal group, pancuronium, the second longest. After that came the fastest acting muscle relaxant, which is called as rocuronium. Then came the most cardio-stable muscle relaxant. Okay, we'll discuss that later. So remember guys, if someone asks you, the question was what? Patient is having renal failure. If the patient is having renal failure, you want to avoid the drug that is having renal excretion. Only one muscle relaxant is there or two muscle relaxant is there that will bypass the kidney and bypass the liver. What are the two? Atra and cisatra, which is given in the option atracurium. So you can easily go with atracurium. All others are having some excretion through the renal tract. Is it clear? Okay, next. Okay, if someone asks you what is the shortest acting and what is the longest acting muscle relaxant, you have to tell my short dog has long tail. My short dog. M से क्या याद रखेंगे? M. Mevaquarium is the shortest acting muscle relaxant. Dog has long tail means Doxycurium has, or Doxycurium is the longest acting muscle relaxant. Okay, second longest acting is pancuronium. If someone asks you regarding pancuronium, you have to tell what? Pancuronium. Remember guys, RRR movie was a pan-India movie. Okay, RRR was pan-India movie. Pancuronium means RRR, you have to remember. Pancuronium, someone asked, pan means RRR. Why R? R say what you will remember? Pancuronium rate. Rate is what guys? Pancuronium increases the BP and pulse rate. Hence it is regarded as a muscle relaxant of choice in shock. Next, pancuronium causes recovery. What recovery? As pancuronium is having a long duration of action, it will cause a delayed recovery to the patient. Last R is what guys? Renal. Pancuronium is having maximum renal excretion. Hence it is contraindicated in renal failure. Contraindicated in renal failure. All three MCQ points of pancuronium are covered. Next was vecuronium guys. Vecuronium is regarded as the most cardio-stable. Vecuronium. V for vecuronium, V for Valentine's. What is common between vecuronium and Valentine's? Heart is common. So you have to remember guys, V when you are writing of vecuronium, draw like this, it looks like heart. So vecuronium is the most cardio-stable muscle relaxant. Most cardio-stable muscle relaxant. Most cardio-stable IV induction agent was what? Ethomidate. But it is having excretion through the biliary tract. Biliary excretion it is having. Hence, it is contraindicated if the patient is having obstructive jaundice. Last is what guys? Rocuronium. Rocuronium में क्या याद रखेंगे? Rocuronium. With the name Rocuronium, you can easily remember. I used to remember Rocuronium as a painful rock star. Rockstar is a fast acting person. So Rocuronium is the fastest acting. With RO also you can remember. RO means rapid onset. RO is rapid onset. So Rocuronium is the fastest acting muscle relaxant. Fastest acting muscle relaxant. Which muscle relaxant? Non-depolarizing. In depolarizing it is always succinylcholine. Okay. And it is always a painful injection. Painful injection. Next. A 6-year-old child is undergoing general anesthesia for elective surgery. Induction is done with sevoflurane. Normally, for children, induction is done with sevoflurane. Why? Because it's having a very good odor. Okay? The anesthesia machine is set at a low flow of gases for maintenance. Which of the following complication is most associated with this setup? Come on, guys. What's the answer for this? Hepatotoxicity, nephrotoxicity to compound A, malignant hypothermia, and diffusion hypoxia. Guys, remember, sevoflurane is what? Sevoflurane is a very pleasant gas commonly used for induction as well as maintenance in children. So sevoflurane is a special inhalational agent used for induction as well as maintenance of anesthesia. It is the best inhalational agent used for bronchial asthma. Bronchial asthma. It is the best inhalational agent used in children. Best inhalational agent used for decade surgery. And best inhalational agent used for neurosurgery. But sevoflurane should never be used in low flows. If you use sevoflurane in low flows, it reacts with soda lime to form a compound called as what? React with soda lime. In closed circuit, you are having a absorbing material called as soda lime. It reacts with soda lime to form a compound called as compound A or olefin, which is a nephrotoxic compound. Hence, it is avoided in renal patients also. So, in low flows, nephrotoxicity could be seen due to compound A formation. Okay. Sivo, I used to remember Sivo Sevenya. यानी कि Sevenya sweet. Color of Sevenya is yellow. So sevoflurane is having sweet odor stored in yellow color vaporizer. Okay? Done. Next is isoflurane. Guys, remember isoflurane is the most commonly used inhalational agent in cardiac surgery. It can be safely given in renal patient, but the side effect of isoflurane is what? Isoflurane, it's seen in animal, guys. Isoflurane can cause coronary steal phenomena. Coronary steal phenomena. What is coronary steal phenomena? Basically, when you give isoflurane to the patient, the blood from the bad coronary is being stealed and given to the good coronary artery. Reverse Robin Hood phenomena is coronary steal phenomena. That can be seen with isoflurane. Okay. Next, guys. Guys, just solve this MCQ. In 1 minute, I'll join. 1 or 2 minutes, I'll join. Take it. Just solve this MCQ in 1 or 2 minutes, I'll join. Yes. So, which inhalational agent is most commonly likely to cause diffusion hypoxia at the end of surgery? Guys, remember, there is one inhalational agent that can cause it, that is nitrous oxide. What happens is nitrous oxide is usually accumulated in the alveoli when you are giving nitrous, and it displaces the oxygen out of the alveoli. So what we do is, at the end of surgery, while cutting down the gases, first we increase the flow of oxygen and then we cut down the nitrous. Why? Because just in order to avoid this diffusion hypoxia. When we are discussing nitrous oxide, we have to discuss some of the points of nitrous oxide. Remember, nitrous oxide is an inhalational agent that is having a very high MAC value. Remember, MAC indicates the potency. Any inhalational agent that is having a high MAC value will be low potent, or it will be least potent inhalational agent. So nitrous cannot be used as a sole gas. It is always used as a carrier gas. Carrier gas means what? With other inhalational agent, you are using nitrous. What is the color of nitrous cylinder? Nitrous means, you have to remember, the color is Neela. Neela is the term given for blue color cylinders of nitrous. It is a very good analgesic agent, but nitrous should be avoided in closed loop surgeries and cardiac surgeries. Closed loop surgeries, if you give nitrous, it will accumulate and it will lead to, basically, guys, remember, closed loop surgery means if the patient is having intestinal obstruction, example, don't give nitrous. It already, there is something that is accumulated. If you give nitrous, what will happen? It will basically dilate that part of the intestine and it can lead to rupture of the intestine also. Okay. So with nitrous, we can see diffusion hypoxia. Hence, at the end of surgery, we are giving 100% of oxygen for 5 minutes. And you will also see one more effect called a second gas effect. Second gas effect, what is second gas effect with nitrous? Remember, nitrous, when you are mixing, always nitrous you are giving with other inhalational agent, either halothane, either sevoflurane. What will it do? It will increase the concentration of other agent. It will increase the concentration of other inhalational agent. That is called as second gas effect. That is usually seen with nitrous oxide. Okay. Next. Right. A patient develops immune mediated hepatic necrosis after repeated exposure of an inhalational agent. Which agent is likely responsible? Remember, guys, regarding liver, hepatic, only one agent, if you are using it repeatedly, that can cause immune related hepatitis. That is called as what, guys? HIH, halothane induced hepatitis. HIH. So if someone is asking you about halothane, your answer should be what? Halothane means 4 H's of halothane, which will cover all MCQs of halothane. What are the 4 H's of halothane, guys? The first H of halothane is what, guys? Hyperthermia. Yani ki halothane can cause malignant hyperthermia. ठीक है. Almost all inhalational agents can cause malignant hypothermia. Maximum is seen with halothane. Next is what, guys? Halothane is contraindicated in heart disease. Why? Because it causes hypotension, bradycardia, as well as increases the sensitivity of myocardium towards catecholamine. Next stage of halothane is what? Halothane can lead to hepatitis. What hepatitis, guys? Immune related hepatitis it can cause. Hepatitis. Okay. Next, halothane has two maximum. What maximum? It can cause maximum bronchodilation and maximum muscle relaxation. Even though it is causing maximum bronchodilation, but still it increases the airway resistance. Hence, most commonly for bronchial asthma, what we are using is sevoflurane. Why? Because halothane can cause increase in the airway resistance, even though causing some bronchodilation. Okay. Next, guys, look over here. Which inhalational agent has the highest MAC value? Highest MAC value means which is the least potent. Now look over here, guys. Highest to lowest MAC value. First of all, MAC indicates what of the drug? MAC indicates the potency. Before solving this, MAC indicates the potency of the inhalational agent. MAC is minimal alveolar concentration. High MAC value is equals to least potent, and low MAC value is equals to more potent. Okay, that is, remember, inhalational agent is working on two principles. One is the MAC, other is the principle of blood gas coefficient. MAC indicates the potency, blood gas coefficient indicates the speed of onset and recovery. Okay, same, remember, MAC is always opposite to the potency. Blood gas coefficient is also opposite to the speed of onset and recovery. High blood gas means slow onset and low blood gas means fast onset and fast recovery. Now, guys, look over here. The question was which inhalational agent is having highest MAC value. The mnemonic for low to high MAC. Low to high MAC. The mnemonic is what? HISD. Low to high MAC. H stands for halothane. Halothane is having a low MAC value, hence it is the most potent. Okay, low to high MAC. Then isoflurane, then sevoflurane, then desflurane. Desflurane is having a high MAC value. Hence it is the, hence it is the least potent. Okay. So over here, what's the answer? Desflurane. Now to this mnemonic you can add M. M is methoxyflurane, not commonly used, but it is having a low MAC value, more low than halothane. But guys, remember, that's not important. Important is to remember this. Low to high MAC value, the mnemonic is HISD. But if you go in the opposite direction means DSIH. If I write in the opposite direction, I'll get what? Drugs having low blood gas to high blood gas coefficient. Low blood gas to high blood gas. What does it mean? Low blood gas means what? Fast to slow onset. What is that? Desflurane is the fastest. Okay, next sevoflurane, second fastest. Next isoflurane, last slowest is what, guys? Halothane. Is this thing clear? That is regarding the MAC and blood gas coefficient. So the answer for it is what, guys? Desflurane. Right? Most to least potent, I have already told you, HISD, and agent having low blood gas to high blood gas, or it comes in DSIH. You can fill in your workbooks later. Okay. Next, train-of-4 ratio of more than 0.9 suggests what? First of all, guys, my ex has DNS, I hate more. Okay. Train-of-4 ratio of 0.9 suggests what? First of all, guys, remember, train-of-4 ratio is done for major surgeries where you are expecting a longer duration of anesthesia. There you have to go for train-of-4. Train-of-4 ratio tells you how deep the muscle relaxant is working or not. Okay? A ratio of more than 0.9 suggests what? Guys, remember, first of all, just look over here. Train-of-4 ratio mein just is very simple. What you do is you take this, you basically apply electrodes. Okay? The muscle that is commonly used is adductor pollicis, and the nerve commonly used is ulnar nerve. Okay? After applying electrodes, you give 4 twitches to the patient. You basically stimulate the patient, and on each stimulation you will see a twitch response coming. Just look over here, guys. This is the twitch response. I have not received any muscle relaxant. If trainer 4 is applied to me, once 4 stimulations are giving, what response you will see? Just look over here. First, second, third, fourth. Yani कि 4 responses you will see like this. Just look over here. First response like this, second response same like this, third response same like this, and fourth also same like this. Yani कि T1, T2, T3, T4. Yani कि if someone tells you what is the train of 4 ratio in a patient who's not given any muscle relaxant, you will tell what? T4 by T1 is the train of 4 ratio. It will be what, guys? 1. But if I received a muscle relaxant, that too a depolarizing muscle relaxant, what will happen to my train of 4 ratio? Just look over here, guys. I have received scoline after 30 seconds or after some seconds of scoline. You will see you have applied the train of 4. Now you will see, give the stimulus. You are stimulating my ulnar nerve. You will see what? First twitch, second twitch, third twitch, fourth twitch. Remember, before receiving muscle relaxant, I was like this. After receiving scoline, what you will see? First twitch, second twitch, third twitch, fourth twitch. Come on, guys. So after receiving a depolarizing muscle relaxant like scoline, what will be the train of 4 ratio? That's my question to you. What's the answer? Remember, this is the normal one. After depolarizing, what is happening? All twitch heights are decreased, but they are decreased in the same amplitude. Yes or no? So how will be the train of 4 response? T4 by T1. Same, all heights are same. So it will be also 1 in case of depolarizing. Whereas, guys, in case of non-depolarizing, how will you come to know in case of non-depolarizing what is the like effect? Just look over here, guys. If I received a non-depolarizing muscle relaxant, what will happen? First twitch, second twitch, third twitch, fourth twitch. Yani कि what you will see in case of non-depolarizing muscle relaxant, the response will be something like this. First twitch, second twitch, third twitch, and fourth twitch. Yani कि basically you will see a faded response. You will see a faded response. So how will be the ratio in case of non-depolarizing muscle relaxant, guys? It should be less than 0.4. Okay? What ratio? If you see a train of 4 ratio more than 0.9, it indicates what? Patient has adequately, now patient can be, the patient is adequately recovered from the muscle relaxant effect and he can be extubated. In case of deep blockade, you will see a ratio less than 0.4. In case of phase 2 block, what is phase 2 block? If you have given succinylcholine in a very high dose, 7 mg per kg body weight, then succinylcholine will act as a non-depolarizing muscle relaxant and you will see a ratio of less than 0.4. Okay? In case of non-depolarizing, always the ratio will be less than 0.4 only. A ratio more than 0.9 indicates what? The patient is adequate for the reversal. Okay? Is this thing clear, guys? Yes or no? Okay. So in train of 4 monitoring, remember 4 stimulus are given over a gap of 2 seconds. Frequency is 2 Hz. Most common nerve that is being used is ulnar nerve and the muscle is adductor pollicis. Adductor pollicis. Okay. The train of 4 ratio in depolarizing, it is 1. In non-depolarizing, the adequate block, the train of 4 ratio should be less than 0.4. For reversing, always the ratio should be more than 0.9. Very important. More than 0.9. There is train of 4 ratio. Apart from train of 4 ratio, there is train of 4 count also. Train of 4 count means what? If the 4 twitches, remember I told you 4 twitches are there. 1 twitch, second twitch, third and fourth twitch. If there is no 4th twitch, what does it mean? If the 4th twitch disappears, that means 75% of the receptors are blocked. If 3rd twitch disappears, yani कि 1, 2, and there is no 3rd twitch coming, 4th twitch is not coming, 3rd is also not coming, that means 85% of receptors blocked. 2nd twitch disappears, 95% of the receptors are blocked. And if 1st twitch disappears, that means 100% of the receptors are blocked. Which is the first twitch to disappear, guys? It is always the T4. And which is the first twitch to recover? It is always the T1. Okay, that's regarding the train of 4 count. Okay, Next, so as we are discussing something about trainer 4 and all, we'll go to the monitoring. Remember guys, in anesthesia, what are the things you're monitoring for? You're monitoring for the patient's oxygenation with the help of pulse oximetry. Pulse oximeter usually works on a law which is called as Beer-Lambert's law. Okay. Apart from that, what you need to remember, ventilation. Ventilation, how are you monitoring? Ventilation is monitored by what guys? Capnography. Okay. Next, circulation. How will you monitor the patient's circulation? Circulation is monitored by blood pressure, ECG, and TEE. In blood pressure, there is invasive and non-invasive both. Invasive is done for again major surgeries. And what is the artery that is commonly used in invasive? It is a radial artery. But before cannulating the radial artery, you have to check the patency of radial artery. With the help of Allen's test, you will come to know whether it is patent or not. Okay. In ECG, you don't look for all 12 ECGs, all 12 leads. You are just looking for lead 2 and lead 5. Lead 2 detects arrhythmias, whereas lead 5 detects ischemia. Okay. There is one more monitoring called as transesophageal echocardiography. This is done for a patient who you are suspecting venous air embolism. Venous air embolism means surgery which is done in a sitting position and where the where you have suspected that air has entered the major blood vessel. There you can go for transesophageal echocardiography. The murmur that you see in venous air embolism is Millwheel murmur. Okay. Temperature. For temperature, guys, what are the things? Which temperature you are monitoring? Core and peripheral temperature. Core temperature, there are sites. The most commonly used site is basically the esophagus, most commonly. But the most accurate site is pulmonary artery. But it is an invasive. So we are not going for that. Most commonly, we are going for esophagus for core temperature monitoring. Apart from that, you also monitor the patient is aware or not. Sometimes, remember your inhalational agent that you are giving to maintain the patient in anesthesia state. Sometimes that inhalational agent won't be sufficient to the patient. But how will you come to know that your patient is aware during anesthesia? With the help of BIS, bispectral index, that calculates the sum of EEGs and gives a value. Okay. Now guys, look over here. Target BIS value during general anesthesia. Now I told you BIS is nothing but bispectral index. Remember, BIS values after connecting to the patient, you might get BIS values as 100 or less than 40 or these values. 100 if you are getting, that means what? The patient is fully awake. Okay? If you are getting a BIS value of 60 to 85, that is called as a sedative BIS. Okay? If you are getting a value of 40 to 60, that is a BIS value indicated for general anesthesia. The patient is ready for, patient is in deep anesthesia, but less than 40 indicates deep hypnotic state. Okay, so this is the BIS required for general anesthesia. Deep hypnotic state is not required, less than 40. This is the BIS, guys. This is the BIS, bispectral index monitoring. Next, a patient requires rapid reversal of profound rocuronium blockade immediately after failed intubation. Yani you have given rocuronium and the patient, you are not able to intubate. Now you want to reverse the patient. What is a reversal agent given? Guys, remember, in reversal agents, we are having many reversal agents. Okay? But for rocuronium, it requires a special reversal agent. The most commonly used reversal agent is neostigmine. It is a cholinesterase inhibitor. As you give neostigmine to reverse the muscle relaxant effect, it will cause bradycardia to the patient. So in order to prevent that bradycardia, we add neostigmine with either atropine or either glycopyrrolate and give to the patient. Okay, neostigmine is commonly used, pyridol is used, L-cysteine is used, edrophonium is used, but Sogamadex is commonly used for rocuronium and vecuronium. So in our question, it was rocuronium. So the best reversal agent is what? Sugamadex. And the best quality of Sugamadex is, when you give Sugamadex, there is no need of giving glycopyrrolate or atropine. Only neostigmine, when you give, you have to give that. Remember, there is one more reversal agent called as physostigmine. It is not used as a reversal agent. Why? Because it causes blood-brain barrier. So over here, guys, what's the answer for rapid reversal of rocuronium? It is the Sugamadex, modified gamma cyclodextrin. Okay, but what is the signs of adequate reversal? Before reversing the patient, you have to see a best sign. But the best bedside sign is you tell the patient to do a head lift. You tell the patient to lift your head. A sustained head lift of more than 5 seconds is a best bedside sign. Okay, sustained head lift of more than 5 seconds, more than 5 seconds. Okay, overall the best sign is what? The train of 4 ratio more than 0.9 is the overall best sign. Next guys, this is the summary of all general anesthesia just now we have discussed. Just look over here guys. If the patient is having heart condition, what is the IV induction agent? If you want to give general anesthesia to a patient who's having heart disease, what is the IV induction agent? What is the muscle relaxant? And what is the inhalational agent? So remember guys, heart disease patient, you always have to remember like this. Heart enjoys very deep inhalation. Very deep inhalation. What does it mean? Heart enjoys means what? What is the IV induction agent that starts with E? It is ethomidate could be used. Okay. What is the IV induction agent that starts with V? Vecuronium could be used over here. What is the inhalational agent that could be given? I told you heart enjoys very deep inhalational. So D stands for best is desflurane, but again desflurane comes with a very costly vaporizer. Hence the most commonly you will use is what? Isoflurane. This is very important slide guys. Okay. Next, asthma. For asthma, what you need to do? Asthmatic, you have to remember, asthmatic kids always seek help. Asthmatic kids always seek help. What does it mean? The IV induction agent of choice for asthma is starting with K, ketamine. Always means any of the muscle relaxant you can give except benzyl isoquinoline you are avoiding. Why? Because benzyl isoquinoline releases histamine that can cause allergic reaction and all. So usually it is avoided. S stands for what? In asthma, the IV induction, the inhalational agent is what guys? Sevoflurane. The second best is what? Halothane. Next, shock. For shock, what we have to remember, the mnemonic shock kills the patient directly and indirectly. Okay. So what is the IV induction agent of choice for shock? You give ketamine when a patient is in shock. What is the muscle relaxant of choice in shock? You give pancuronium, RRR of pancuronium. And what is the inhalational agent? Best is desflurane, but most commonly we use isoflurane. Reason, desflurane is coming with a costly vaporizer. Next, daycare surgery. The mnemonic is patient may sleep. Patient means what? The daycare surgery, the IV induction agent of choice is propofol. And muscle relaxant of choice for daycare surgery is mevacurium, the shortest acting non-depolarizing. And the inhalational agent for daycare surgery is sevoflurane. Initially it was desflurane, but desflurane causes airway irritation and laryngospasm. Hence we are using sevoflurane. Neurosurgery. For neurosurgery, what we need to remember guys? Remember the mnemonic is neurosurgeons. Mnemonic is neurosurgeons treat all safely insane. Okay. So what is the IV induction agent? With T, thiopentone. Okay. Muscle relaxant, any muscle relaxant could be given. An inhalational agent, best is sevoflurane, and the second best is what guys? It starts with isoflurane as the second best. Basically guys, this is the mnemonic for what? This is the mnemonic for the whole general anesthesia. Okay. Now coming to the next question guys. During anesthesia with sevoflurane, that slide was very important. Okay. During anesthesia with sevoflurane, a patient develops rapid rise in ATCO2, tachycardia and muscle rigidity. What's the next best step? Guys, remember with sevoflurane or during anesthesia, if the patient is having a rapid increase in the ATCO2 and muscle rigidity, it is giving you towards a diagnosis of what? It is giving you the diagnosis of Malignant hyperthermia. And what is the next best step for managing malignant hyperthermia? You have to give antipyretic, but not the best step. You have to increase the ventilation, not the best step. You have to administer sodium bicarb, not the best step. First is the stop the triggering agent. If sevoflurane is given, stop it and give 100% of oxygen. Stop the triggering agent, and then you need to go for the drug of choice for malignant hyperthermia. What is the drug of choice for malignant hyperthermia, guys? IV dantrolene sodium. Now, something about malignant hyperthermia. Malignant hyperthermia can be triggered with the local anesthetic called as lignocaine. Malignant hyperthermia can be triggered with all inhalational agents, maximum with halothane. Okay. Malignant hyperthermia can be triggered with succinylcholine. Okay. Remember, all inhalational agents can trigger malignant hyperthermia except nitrous and xenon. These are safe. What is malignant hyperthermia? It is usually seen in autosomal dominant patients. Okay, what is the gene responsible? RYR1 gene is responsible. And if you give choline, or if you give any of the triggering agents to an autosomal dominant patient, it will go towards the abnormal ryanodine receptors and it will stimulate the ryanodine receptors. Once the ryanodine receptors are stimulated, patient will develop, there will be rapid release of calcium. Due to that, the patient will develop what? Muscle spasm. This muscle spasm usually starts from what muscle? Masseter muscle. Thereby the whole body gets involved. How will you diagnose malignant hyperthermia? With the help of halothane bath or halothane caffeine test. Halothane caffeine test. And what is the drug of choice for malignant hyperthermia? It is always IV dantrolene sodium. IV dantrolene sodium. Okay. Now, guys, something related to malignant hyperthermia, or you can say basically something related to the capnography. Just look over here, guys. In malignant hyperthermia, how will be the capnograph that you see? In malignant hyperthermia, the capnograph that appears is like this. Okay? What do you see, guys? What is happening over here? You will see either like this capnograph, or sometimes capnograph in malignant hyperthermia, sometimes it is increasing like this. So it is step ladder increase in the capnography. Now, guys, as we are discussing capnography, some points of capnograph we need to remember. Capnograph is nothing but it is the graphical representation of exhaled carbon dioxide. Okay? Once you have intubated the patient, connect the tube to a capnograph. That indicates after connecting the tube to the capnograph, if you see this kind of graph, that indicates you are in the trachea. So basically the surest sign or the surest test to confirm intubation is what? It is capnography. Capnograph, what is the normal value that we get, guys? 35 to 45 mm of Hg. This is the normal capnograph reading that we see. Okay, this capnograph is divided into 4 phases, guys. What are the 4 phases of capnograph? Just look over here. Phase 1 is called as inspiratory baseline. Phase 2 is called as expiratory upstroke. Phase 3 of capnograph is called as alveolar plateau. And phase 4 of phase 0 of capnograph is called as inspiratory downstroke. Between phase 2 and phase 3, there is an angle called as alpha. Between phase 3 and phase 0, there is an angle called as beta. Capnograph is measured at this angle. Very, very important. Capnograph or EtCO2 is measured at this angle called as beta. Okay. Now, guys, after intubating, you have to see this capnograph that indicates you are in the trachea. But imagine, guys, after intubation, you see a flat line. What does it indicate, guys? If you see a flat line after intubation, you see a flat line. There is no graph coming. You might be basically in the esophagus, not in the trachea. Okay. Sometimes you are in the trachea, but you all see a flat line. That can also happen. Why? Yani ki immediately after intubation, the patient develops cardiac arrest. You will see a flat line. Or in case of complete bronchospasm, complete shutdown of the bronchus, complete broncho. I'm not saying just bronchospasm. You will see different capnograph. Complete bronchospasm, you will see a flat line. Or circuit, if it is getting disconnected, you will see a flat line. So flat line capnography can be seen in these conditions. Okay. Now, guys, look over here. That is flat line. Next, if you see a shark fin pattern of capnograph, just look over here. Shark fin pattern means what? After intubation, you see this kind of capnograph developing. What does this mean, guys? This looks like shark fin. Okay, shark fin. Shark fin capnography is seen in bronchospasm. When the patient is having bronchospasm, the ETCO2 value might be normal to high in this case. Okay. Next, step ladder increase in capnography. Just now we have discussed. It is seen in malignant hyperthermia. Sometimes capnograph might be appearing like this, guys. Like this means, is it touching the baseline? No, it is not touching the baseline. Starting from the above means what? This kind of capnograph, which is starting above the baseline and the value is 80 to 90, it is seen when the patient is re-inhaling his own carbon dioxide. When does the patient re-inhale his own carbon dioxide? When the thing that absorbs carbon dioxide is gone. What is the thing that is absorbing carbon dioxide? Soda lime. If soda lime is exhausted, you will see a capnograph above the baseline, or if there is an expiratory valve that is faulty, expiratory valve that is faulty, there also you will see capnograph above the baseline. Okay. Now, patient was having capnograph normal, but suddenly what do you see is capnograph falling. Capnograph falling. Sudden fall of capnograph is seen in the cases of venous air embolism. In cases of what, guys? Venous air embolism. Okay. Next, during anesthesia, you are seeing a capnograph developing like this, which was normal. Slowly you are seeing a notch developing. A notch developing is nothing but a Curare notch. It indicates return of what? Return of spontaneous ventilation. Spontaneous ventilation. If you see this kind of capnograph occurring during the time of anesthesia, the next best step would be what? Next step is you have to give the top-up dose of muscle relaxant. Next step is give top-up dose of muscle relaxant. Okay. Next, in case of hyperventilation, guys, what you will see? Which kind of capnograph you will see? If at all you are hyperventilating, means you are increasing the respiratory rate. You are increasing the respiratory rate means you are basically washing out the carbon dioxide. So you will see a capnograph developing like this, carbon dioxide being washed, and capnograph which is coming like this. In case of hypoventilation, you will see a capnograph coming like this. And you are decreasing the respiratory rate, so carbon dioxide will increase. Okay. Next, during RSI, after induction in paralysis, the anesthesiologist avoids mask ventilation. Come on, guys. What is RSI first of all? What is RSI? RSI is nothing but what? Rapid sequence induction. Anesthesia. Basically, it is very simple. General anesthesia given to full stomach patient. Patient who is full stomach. Pregnant lady is considered full stomach. Obese patient is considered full stomach. Okay. Road traffic accident patient, they are considered what? Full stomach. Rapid sequence induction is nothing but general anesthesia given to full stomach patient. Obese, pregnant lady, GERD, or any emergency. That is called as rapid sequence induction. So you avoid, or anesthetist avoids, bag mask ventilation. What is the reason for it? To prevent hypoxia, to prevent gastric insufflation? No. Okay. Basically, remember, you just give oxygenation to the patient with normal mask, not bag mask. If you give bag mask ventilation, already the patient is full stomach, there is a chance of aspiration. Okay. So guys, remember, in rapid sequence induction, what is rapid sequence induction? General anesthesia given to patients who are at risk of aspiration. What is the step that we do? We pre-oxygenate the patient with normal mask. What is being avoided, guys? Okay. What is being avoided? BMV is avoided. BMV is avoided. Bag mask ventilation is avoided. Next, immediately after IV induction, you tell your assistant to put pressure on the cricoid cartilage so that the upper end of the esophagus is closed. What is that called as? This is called as Selleck's maneuver. Selleck's maneuver. Immediately after IV induction, pressure is applied on the cricoid cartilage. Cricoid cartilage to close down the esophagus. Okay. So now look over here. Once intubation, when do you remove the Selleck's maneuver? That is also very important. Once intubation is done and cuff is inflated cuff, Then you remove Selix maneuver. Then you remove the Selix maneuver. Okay? Next. A pediatric patient requires IV antibiotics. Veins are very small and fragile. Which cannula is the best for this patient? IV cannulas are available from different sizes 14 to sizes 26. Which cannula should be preferred? Remember guys, 14 gauge means it's a very large diameter cannula. 14 and 16 are usually used when the patient is in shock and usually used in adults. Okay? Remember, in pediatric cases, you go above 22. 22 can be used, 24 can be used and all. So the answer over here is 22 gauge IV cannula. Now look over here guys. For IV cannulas, these are the different gauge sizes of IV cannula. The mnemonic that you need to remember for, they have been asking on color of IV cannula and flow rate of IV cannula. The mnemonic that we need to remember is, oh great God, please bless your people. When I am saying, oh great God, please bless your people, O stands for orange color IV cannula, which is 14 gauge. G stands for grey color cannula, 16 gauge. G stands for green color, which is 18 gauge. P stands for pink color, 20 gauge. B stands for blue color, 22 gauge. Yellow is, then Y stands for yellow, which is 24 gauge, and P stands for purple, which is 26 gauge. And what is the flow rate? If you want to remember the flow rate, you should go from down to down to top. So with 26 gauge, you can give 10 ml per minute of fluid. Okay, with 26 gauge. With 24 gauge, add more 10, 20 ml per minute. 22 gauge, 30 ml per minute. 20 gauge, 50 ml per minute can be given. 18 gauge, 100 ml per minute of fluid can be given. 16 gauge, I am telling the approximate values, near about approximate values. 16 gauge, it is 200 ml per minute. And with 14 gauge, it is 270 ml per minute of fluid that can be given to the patient. Okay? That is the flow rate that we need to remember, and that is the gauge sizes that we need to remember in the IV cannula. Next guys. A patient develops hypoxia intraoperatively. You notice a blue cylinder was accidentally connected instead of oxygen. What was administered? Guys, remember, this is a common mistake. That's why in order to prevent this common mistake, all the gases are given different color coding on the cylinder. On the cylinder color, if you see a color code of black body, white shoulder, it indicates oxygen. But over here, a blue cylinder was connected instead of oxygen. What is that blue cylinder that was given to the patient? Blue yani ke neela. Neela means nitrous. So nitrous was given to the patient. Before going to the cylinder colors, we need to understand some parts of the Boyle's machine. Guys, remember guys, this is the anesthesia workstation or the Boyle's machine, which is divided into high pressure, intermediate pressure and low pressure system. In high pressure system, you are having cylinders, you are having yoke valve assembly, you are having pressure gauge, you are having pressure regulating valves. In intermediate pressure system, flow control valve, oxygen nitrous proportionating devices and oxygen flush is there. Then low pressure, rotameter, vaporizer and all breathing circuits come under low pressure. Guys, I'm not going into the detail of it. Now, the most important points of the machine will go into detail. The cylinder is made up of what material? It is made up of molybdenum. But guys, this molybdenum cylinder are non-MRI compatible, cannot take into the MRI room. If you want to take a cylinder into MRI room, it should be made up of aluminium or titanium. Okay, what is the size of cylinder? The small size cylinder is size A, the largest is size J cylinder, and most commonly used size cylinder is size E cylinder. Okay, now guys, these cylinders are given different color coding in order to identify the gas which is present in it. Oxygen is basically a bodyguard for us during anesthesia. If you keep a bodyguard with you after you become a big doctor, the bodyguard who you keep, he will wear what color? He will wear a black uniform with white shoulder coupling. So oxygen is like a bodyguard to us. So oxygen cylinder color would be what guys? It would be black body, white shoulders. Okay. Air cylinder color would be what guys? Opposite of oxygen, that is white body and black shoulders. In some countries, air cylinder color is what guys? It is gray body and black and white shoulders. In some countries, gray body and black and white shoulders. Next, nitrous is what? Nitrous is very simple. It is nitrous neela. I won't be writing, it is blue color. Okay, Entonox. Entonox is nothing but mixture of 50% of nitrous, 50% of oxygen. Entonox is basically given for analgesia purpose, not for anesthesia purpose. So Entonox cylinder color is what, guys? Blue body, white shoulders. Okay. Next, carbon dioxide is complete gray in color. Carbon dioxide is used for the gas insufflation during the laparoscopic surgeries. Okay, that's regarding what, guys? Cylinder color. Now, if you look at the shoulder color, now guys, remember, colors of cylinder is very important and shoulder color is very, very important. Why? I'll tell you. Why? Because in any hospital, apart from cylinders, we also have central supply of gases. Central supply of gases will be coming from the pipeline, and these pipelines are also color coded. If it is an oxygen pipeline, what is the color of it? It is always the shoulder color of the cylinder. So what is the pipeline of oxygen? It is white in color. If it is an air cylinder, air pipeline, the shoulder color of air cylinder is what? Black in color. If it is nitrous, it is, remember, nitrous is totally neela, so color is what, guys? Blue. Pipeline color is blue. If it is vacuum, vacuum is used for suction and all. What is the pipeline color for vacuum? Remember, guys, vacuum starts with V. If you add a small stroke to this V, it becomes Y. So vacuum color is yellow. The pipeline color is yellow. Okay. Now there is one more thing which is called as pin index system. Guys, what is pin index system? Pin index system is nothing but what? It is a system that prevents wrong attachment of the cylinder to the machine. Okay. Where pins are present on the machine and holes are present on the cylinder. Just look over here, guys. 1, 2, 3, 4, 5, 6. We'll just label them 1, 2, 3, 4, 5, 6, and there is 7 pin. Okay. So different gases are given different pin index system. Air is given a pin index system of 1, 5. Oxygen is given a pin index system of 2, 5. Nitrous is given a pin index system of 3, 5. Entonox is given a pin index system of 7. Carbon dioxide, it is 1, 6 and 2, 6. But how do you remember this? Guys, remember, just look over here. Air 1, 5. Remember, air, oxygen, nitrous, it's very simple to remember. Why? Because all these three gases have one thing in common. The second pin is what? 5. We just have to remember the first one. So if it is air cylinder, the pin index would be what, guys? 1, 5. How am I telling 1, 5? Why? Because air starts with the alphabet A. Alphabet A is the first alphabet. So it is 1, 5. Oxygen, pin index would be what? Second is always 5 only. So the first pin is what? O2 you are writing. Now this 2 will come over here and it will be 2, 5. Nitrous. Okay? Second pin, always remember 5 only. Nitrous. 2 molecules of oxygen, 2 molecules of nitrous and 1 nitrogen and 1 molecule of oxygen, it becomes 3. So it is 3, 5. Entonox is very simple, guys. 7. Okay? Entonox means 7 means it will just fit into the 7th port. Okay? 7. There are 7 alphabets in the term Entonox, so you can remember Entonox. Carbon dioxide, you have to buttify, that is 1, 6 or 2, 6. Okay? Next, vaporizer. Yeah, vaporizer. Vaporizer is a device that stores the liquid inhalational agent. What is the material by which vaporizer is made? It is made by the copper. Okay? All vaporizers are made by copper. But desflurane requires a special vaporizer. Why? Because it's having a low boiling point. Low boiling point. Okay, and it is a very costly vaporizer. The vaporizer that we use is Tech 6 vaporizer. This vaporizer comes in different colors. For halothane, what is the color, guys? Halothane, you have to remember halothane, hellfire is red in color, so you need to remember the color of halothane vaporizer is red. Isoflurane, it is purple color vaporizer. Sevoflurane, sevo yani ki sevaiya, which is sweet in odor, that is sweet odor. That means what is the color of the sevoflurane vaporizer? Yellow in color. Desflurane, if someone asks you about desflurane, what is the color of desflurane vaporizer? Remember, guys, des means desi. Desi jersey color is what? Our cricket jersey color is blue. So blue color vaporizer. Okay. Next. During controlled ventilation in the operation theatre, carbon dioxide retention is noted despite adequate ventilator setting. Which circuit is most appropriate to reduce this? Come on, guys, what's the answer for this? Controlled ventilation, what is the circuit of choice? In Mapleson, we are having Mapleson A, B, C, and D. Mapleson A circuit is used for spontaneous ventilation. B and C we are not using. Mapleson D circuit is a circuit of choice for controlled ventilation. What is the other name for Mapleson D circuit? It is also called as Bain circuit. So remember guys, Mapleson A circuit is called as Magel circuit, which is a circuit of choice for spontaneous ventilation. Okay, in order to avoid the risk of rebreathing, fresh gas flow should be equal to minute volume. But remember guys, Magel was the guy who did modification with this circuit. What modification he did to this circuit? He added a inner tube. This inner tube was responsible for what? This is an important MCQ. In Mapleson A, the inner tube is responsible for expiratory gases and the outer tube is responsible for inspiratory gases. Guys, remember that circuit was introduced long back. That's why they just did ulta pulta, yani ke inner was responsible for expiratory, outers was responsible for inspiratory. But then came Mapleson D circuit, which is nowadays used for what ventilation? It is a circuit of choice for controlled ventilation. And this circuit was also modified by a guy called as Dr. Archie Bain. Hence it is called as Bain circuit. Here, in order to avoid rebreathing, the fresh gas flow should be equal to 1.6 times the minute volume. But look over here guys. Here also Dr. Bain, he did modification with this circuit. He added an inner tube to this circuit. And here he kept it very straightforward. The inner tube was responsible for inspiratory gases and the outer tube was responsible for expiratory gases. Okay, next, Mapleson E circuit. B and C we are not using. Mapleson E is a bagless and a valveless circuit. It is also called as ISTPs, used for weaning the patient from ventilator or shifting the patient from one location to other location. We can use it. Next is Mapleson F circuit. Mapleson F circuit was nothing but a modification to type E circuit by a guy called as Jackson-Rees. Hence, this is called as Jackson-Rees modification. Okay, this is a circuit of choice for pediatric patient, whether it is controlled or whether it is spontaneous ventilation in pediatrics. You are using Mapleson F circuit. Very, very important, guys. Okay, now guys, these were semi-closed circuit. If you use a closed circuit, there won't be any expiratory valve in closed circuit. All the gases in closed circuit will go into a chamber that will absorb a main gas coming out from the patient, which is called as carbon dioxide. So what is that chamber that absorbs? Either we are having soda lime as an absorbing material, or either barrel lime. What is the soda lime? What is the soda lime that we use in closed circuit made up of? 80% of soda lime is calcium hydroxide, 16% is water, 3% is sodium hydroxide. So the major component is calcium hydroxide, but the main component without which it cannot be formed is what? Sodium hydroxide. And 1 to 2% it is made up of silica, which improves the hardness of the soda lime granules. When you are using soda lime, 3 inhalational agents should never be given, guys. It should be remembered like this: CT scan. C stands for what, guys? Chloroform should not be given. Even nowadays we are not using chloroform. Instead of only thieves are using it. Okay. T stands for what? Trilene. And no thief will take soda lime with chloroform and come to you. Okay. Trilene. S stands for sevoflurane. Now guys, look over here. Why these 3 agents are avoided? Why? Because remember, chloroform and trilene. Chloroform is not used nowadays. Trilene, if you are using with soda lime, it will react with soda lime to form trichloroacetylene that can cause ARDS. Sevoflurane is avoided with soda lime. Why? Because it can form compound A or olefin. Compound A or olefin, which is a nephrotoxic compound. Agents that are avoided with barrel lime. I told you, with as like soda lime. If soda lime is not there in your hospital, you can also use barrel lime as an carbon dioxide absorbing material. But 3 gases should be avoided with barrel lime. What 3 gases, guys? Dye gases. If you use dye gases, patient will die. What 3 gases, guys? D stands for desflurane, I stands for isoflurane, E stands for enflurane. Why? Because they will react with barrel lime to form carbon monoxide. Maximum chance of carbon monoxide formation can be seen with desflurane. Next, guys. A patient is undergoing thyroid surgery, requires an endotracheal intubation endotracheal tube that will not kink despite neck flexion. Okay? Which is the most appropriate? Remember, the surgeon is telling that he will keep the patient in a flexed position and he does not want the tube to kink. If he does intubation with a normal tube, what will happen? The tube will easily kink or tube will easily bend and the ventilation would not be good. Okay? Double lumen tube will you use for this patient? Why will you use double lumen tube? Double lumen tube is a long tube used for one lung ventilation. Here you are ventilating both the lungs. The tube that cannot kink that could be used over here is flexometallic tube. Okay? Flexometallic or armored tube. This is the tube commonly used for patients who are positioned in prone position surgeries or patients who are who are required to keep the neck in a flexed position. You can use this flexometallic or armored tube. Apart from that, there is one more tube that we need to remember that is called as double lumen tube. This double lumen tube is used for what, guys? This is used for surgeries requiring one lung ventilation. Surgeries requiring one lung ventilation. What does it mean, guys? A patient is suffering with lung cancer. The doctor is telling, I will operate on his right lung. Please do not do not ventilate the right lung, only ventilate the left lung. Is it possible? Yes. With a double lumen tube, it is possible. Now, remember guys, in double lumen tube, after placing double lumen tube, how will you confirm that you are in the trachea or you are in the bronchus? How will you confirm? Now, don't tell me capnograph. Capnograph will tell you that you are in the trachea or not. Capnograph won't tell you you are in the bronchus or not. For double lumen tube placement, it can be best confirmed by fiber optic bronchoscope. After placing a double lumen tube, introduce a fiber optic bronchoscope and check whether you are in the bronchus or not. Okay. Next. An unconscious patient with airway obstruction due to tongue fall is brought to the ER. What is the immediate airway agent that could be used? Come on, guys. Patient is in ER and he is having airway obstruction due to tongue fall. What you should do? Endotracheal tube, why will you do? It is not the immediate. It can be the best, but again, it's not the immediate. LMA, why will you keep? Again, it's not the immediate. It can be used. But what immediate should be used? He is unconscious. Okay? If he was conscious, I would have used nasopharyngeal airway. He is unconscious, so there won't be any gag reflex, but he's having obstruction due to tongue fall. So put an oral airway that is called as Goodell's oropharyngeal airway. Okay? Remember guys, patient is unconscious, you can use oropharyngeal airway. If the patient is conscious, you cannot put the oral airway. He will gag and gag on the airway. You can use nasopharyngeal airway at that time. So look over here, guys. We are talking about what? Goodell's oropharyngeal airway. And how do you know which size Goodell's oropharyngeal airway you should use? Take the Goodell's oropharyngeal airway, keep between the tragus of the ear and angle of mouth. If it is fitting, then you can use that size of airway. Okay? Goodell's oropharyngeal airway. But if the patient is having clenched teeth, he is conscious, he is not allowing you to put through the mouth, then in that case you can go for nasopharyngeal airway. But again, nasopharyngeal airway is contraindicated if the patient is having skull base fracture or if the patient is having any bleeding disorder. Don't go for nasopharyngeal airway. Okay, remember guys, Goodell's oropharyngeal airway is very easy to put. Okay, after putting this, then you can ventilate the patient. Is it clear? That's regarding what? That's regarding the Goodell's oropharyngeal airway. Right. During induction, you are unable to intubate the patient and cannot ventilate the patient. Oxygen saturation is falling rapidly. What is the next step? Come on guys, what's the next step? Basically, during intubation, you developed cannot intubate, cannot ventilate scenario. What's the next step? Will you go for repeat laryngoscopy? No. Already you have declared cannot intubate, cannot ventilate. It cannot be done. Insert LMA? No. Inserting LMA was the second step. Remember guys, DAS guideline states what? In DAS guideline, the first step is what? You try to go for plan A. There are 4 plans of DAS guidelines. Plan A is what? You try to go for best attempt of intubation. 3 best attempts failed. Then your aim should be what? I should only ventilate the patient. Once intubation attempt is failed, your plan B should be what? Ventilate the patient. How should you ventilate the patient? By inserting a laryngeal mask airway. Okay? But if that plan B also fails, then you will go for plan C. If you are not ventilating through the LMA, you go for 2% technique. One person will be holding the mask, other person will be holding the bag. That is 2% technique. If plan C also fails, after plan C also the saturation is falling, you're not able to ventilate, you will declare cannot intubate, cannot ventilate. Then you have to activate the plan D. What is plan D? Emergency cricothyrotomy. Emergency cricothyrotomy has to be done in this patient. Okay. Right? He is already told you cannot intubate, cannot ventilate means what? Plan C has failed. He is telling you plan C has failed. Plan C failed means you have to go for plan D, which is called as emergency cricothyrotomy. So you try to go for 3 best attempts of intubation. If 3 best attempts of intubation fails, guys, what we need to do? We need to go for plan B. Plan B is what? Ventilate the patient. Ventilate the patient through what? Ventilate via supraglottic airway device or LMA. Ventilate via LMA. If plan C fails, then you go for, if plan B fails, you go for plan C, which is 2% technique of ventilation. If that also fails, you need to go for plan D, which is emergency front of neck access cricothyrotomy. Is this thing clear? Right? This is the tracheostomy tube, guys. Right? This is a tracheostomy tube. Now, guys, just look over here. As we are doing intubation, we have to know some things about intubation. What things we need to know is basically something about the anatomy. What is the narrowest portion of the adult airway? It is the glottic opening. Glottic opening. And the pediatric airway, what is the narrowest portion? It is the subglottis. Now, if you are planning to intubate the patient, first you need to keep the patient in a position which is favorable for intubation. Then you need to take a scope called as laryngoscope. You have to keep all the things ready, the tube and all. So what is the position favorable for intubation? That is sniffing morning air posture. In sniffing morning air posture, where is the flexion and where is the extension? That has been an MCQ. Where is the flexion? The flexion is at the cervical spine and the extension is at the atlanto-occipital joint. After keeping the patient in this posture, then what we need to do, take a metallic instrument which is called as laryngoscope. Introduce the laryngoscope into the patient's mouth. Okay, there are 2 types of laryngoscope blade. One is called as Miller's, other is called as Macintosh. Commonly for adults we are using what, guys? Macintosh. And for pediatric cases we are using Miller's laryngoscope. Why? Because pediatric they are having a large epiglottis which can be easily lifted through the Miller's laryngoscope. So that is the position. Okay. For obese patient, we are going for rammed up position. For obese patient, we are going for rammed up position. Once you take the laryngoscope and lift the tongue, you will see the laryngeal aperture. If whole laryngeal aperture is easily visible to you, that is called as Cormack-Lehan grade 1. Cormack-Lehan classification is given based upon the viewing of laryngeal aperture. Cormack-Lehan grade 1 means full laryngeal aperture is visible. Grade 2 means only posterior portion of laryngeal wall is visible. Grade 3 means only epiglottis is visible. And grade 4 means epiglottis is also not visible. That is Cormack-Lehan grading. Don't confuse yourself, guys. Cormack-Lehan is done at the time of intubation, not in the pre-anesthetic checkup. In the pre-anesthetic checkup, Mallam Patti is checked. Okay. So basically remember, guys, we take the laryngoscope, we lift the tongue. After lifting the tongue, what you need to do, you have seen the vocal cords, then you have to put the tube. Initially, we were having initially we used to have red rubber tubes. Okay. Best way to secure the airway is by endotracheal tube. Initially, we used to have red rubber tubes, but nowadays we are not using. Why? Because red rubber tubes were high pressure, low volume cuff. High pressure, low volume cuff. That was causing pressure necrosis. Pressure necrosis on the trachea. Hence, we are not using this. Nowadays, we are using what tubes? We are using the PVC tubes. PVC tubes are what? PVC tubes are basically low pressure, high volume cuff. Low pressure, high volume cuff. And after intubating, what is the surest sign that you have intubated? You have to connect it to the capnograph, and that indicates you are in the trachea. But guys, remember there are different sizes tube, 7.5, 8, 8.5. What does that size indicate? Size is nothing but the internal diameter of the tube. Size is the internal diameter, and that internal diameter determines the resistance. The internal diameter determines the resistance. Okay, so look over here, guys. For endotracheal intubation, we keep the patient in which position? Sniffing morning air posture. Take the laryngoscope in your left hand. Introduce it. Lift the tongue. As you are lifting the tongue, you'll see the epiglottis. Epiglottis will be lifted. And once epiglottis is lifted, you will see the vocal cords. Under vision, you have to pass the tube inside the vocal cords. Okay. But if at all, guys, intubation is difficult, if you're not able to intubate, always you can secure the airway with the help of LMA. LMA can be inserted if in case of failed intubation, or in case if the surgery is lasting for a short duration, you can use LMA. LMA is what, guys? Laryngeal mask airway. They are 2 generation or 3 generations of LMA, guys. First generation LMA means what? They are having single port. Everyone listen over here. Single port is the first generation LMA. Example are classical LMA, flexometallic LMA, Cobra LMA, and Ambu Aura 40. These are what, guys? These are first generation LMA. Second generation, when anyone asks you second generation LMA, that means there will be an additional port. Difference between a classical and the second generation LMA is what? Additional port. Additional drain port will be there, through which you can introduce a Ryle's tube and deflate the stomach. Example of second generation are Procel LMA, Supreme LMA, iGel is there, Ambu Gain is there, and Slippa is there. These are second generation LMA. Just look over here, guys. How will you introduce the LMA to the patient? Okay, you will stand behind the patient. This patient was posted for some short duration procedure. So what I did is I pre-oxygenated. I have given the IV induction agent and I have taken iGel. What is iGel, guys? iGel is what? It's a second generation LMA. I hold the LMA in a pen-like fashion and slowly introduce into the patient's mouth, and then I connect to the breathing circuit. Okay, that's regarding what, guys? That's regarding the LMA insertion. Okay, next. Despite drug administration, ROSC is not achieved. What is the most critical factor determining the survival? Come on, guys. What's the critical factor? ROSC is what? Return of spontaneous circulation is not achieved. So what is the most important factor? Drug administration means I am assuming adrenaline we have given. Still we have not achieved ROSC. But the most important factor in the whole CPR is always high quality chest compressions. Very, very important. High quality chest compression. So we are discussing about the steps of or sequence of BLS and ACLS. Guys, remember, if you see any person collapsing, the first step that you do is what, guys? Scene safety. Secure the scene is safe. Second is what? You check for the response, whether he's responding or not. If he's not responding, you call for help. After calling for help, you check for the pulse and breathing. If there is no pulse and no breathing, then you start your CPR. So basically the steps are what, guys? SCCS. S is scene safety, check response, call for help. Next is check for the breathing and pulse, and last is start for CPR or CPCR. Now guys, remember over here, which pulse will you check in adults? It is always the carotid pulse that you check in adults. Whereas in infants, we are checking for what pulse? Brachial pulse. And once there is no pulse, no breathing, no response, that is in a state of cardiac arrest, then you have to start what? CPR. CPR can be done with what? It can be done with CAB or ABC CAB protocol. C stands for compressions, A stands for airway, B stands for breathing. So compressions, how many compressions should be given, guys? Very important. 100 to 120 per minute should be given. Depth of compression should be what? 5 to 6 centimeters or 2 to 2.4 inches in adults. Very, very important. If it is an infant, 1.5 inches or 4 centimeters. If it is a pediatric case, 2 inches or 5 centimeters. Or in pediatric cases who are more than 1 year, you can go for 1/3 of the anterior posterior diameter of the chest. What is the ratio of compression? 30:2. How many sets of 30:2 in 1 minute? 4 sets of 30:2, but you have to allow a full recoil of the chest while giving chest compression to the patient. Okay? Now, if there are one rescuer or more than one rescuer, what will be the ratio? Remember, guys, the compression to ventilation ratio in case of single rescuer in adults, it is 30:2. In pediatrics, also 30:2. In case of more than one rescuer, what is the compression to ventilation ratio? It is same in adults, 30:2. Whereas in pediatrics, if there is more than one rescuer, then you have to go for 15:2. Why? Because pediatric, they are having a high respiratory rate, requires a much breathing. Okay? Imagine you're giving chest compressions and your friend came, or basically in the hospital you're giving chest compression, your friend came and he has intubated. If he has intubated, no need to stop after 30 compressions. What you need to do, every 6 seconds you have to give one rescue breaths. So how many rescue breaths can be given in case of advanced airway placement? 10 rescue breaths per minute. Every 6 seconds you are giving one rescue breath. In case of pediatrics, how many rescue breaths you have to given, guys? It has to be given 20 to 30 rescue breaths per minute. Yani ki every 2 to 3 seconds you are giving one rescue breath. In case of newborns, what is the compression to ventilation ratio? In newborn, it is 3:1. But again, in newborns, neither you are going with you don't give compression with both hands or neither single hand. In case of newborn, you have to go with both thumb technique or 2-finger technique. Okay, depending upon how many rescuers are there. Okay. Next, a 40-year-old man has pulseless ventricular tachycardia. After defibrillation and 2 minutes of CPR, the rhythm persists. Yani ke same VT persists. What is the next step? Come on, guys. The next step is what? If the rhythm is persisting, only one shock has been given. What you need to do? Rhythm is persisting, you have to repeat defibrillation. After 2 shocks, you start adrenaline. Yani ki you are giving adrenaline. And after 3 shocks, yani ki if the after 3 cycles of shock, if the same rhythm is appearing, you with shock you are adding what, guys? Amiodarone. Very, very important. Very important. Okay. So we are talking about, guys. We are talking about the ACLS. So if the patient is having a pulseless VT, pulseless ventricular tachycardia or shockable rhythm. In shockable rhythm, always remember after 2 shocks, what you are doing? Adrenaline. And after 3 shocks, you are going for amiodarone. And after 3 shocks, you are also ruling out what? The reversible causes of cardiac arrest. That is given for what, guys? If the patient is having a shockable rhythm. But if the patient is having non-shockable rhythm means what? If the patient is having flat line, or if the patient is having a normal rhythm but he is having no pulse, yani ke patient is having pulseless electrical activity, that is also considered as asystole. In case of that, you need to just continue the compressions and start adrenaline as soon as possible. Okay? So anyways, guys, we are discussing about what? Shockable. In case of shockable rhythm, shock can be given with the help of manual defibrillator. There are 2 modes, monophasic and biphasic. In monophasic, what is the joules of shock that we need to give? 360 joules. In biphasic, 120 to 200 joules of shock can be given. And what are the shockable rhythms, guys? If you see this kind of rhythm, ventricular tachycardia, that's shockable. If you see this kind of rhythm, a scribbling type of rhythm, ventricular fibrillation, that is also shockable type of rhythm. Okay. Next, cardiac monitor shows asystole after starting CPR. If asystole is there, I told you, what is the first drug that we need to start? Asystole is there, you need to start what, guys? Come on. Atropine, amiodarone, adrenaline or lidocaine. Come on, what should be started? Adrenaline should be started. Now regarding adrenaline, guys, what you need to do? How will you give this adrenaline to the patient? The best route to give this adrenaline is by IV route. But if the IV is not possible, you are not able to secure an IV line, IO route, intraosseous. If intraosseous is also not possible, your friend might have intubated the patient. No, give the drug through the endotracheal route. Okay, but if you are giving through endotracheal route, you have to give 2.5 times the normal dose. What is the dilution of adrenaline that is used in cardiac arrest, guys? The dilution is 1:10,000 in case of cardiac arrest. In local anesthetic, what is the dilution of adrenaline? Adrenaline can be used for local with local anesthetic also. 1:2 lakh. In anaphylaxis, it is 1:1,000. That is a dilution of adrenaline that we need to remember. Is this thing clear, guys? Right. So I told you, if the patient is having asystole, you have to give adrenaline to the patient and 1 milligram, which has to be repeated every 3 to 5 minutes. And then you have to rule out 5 H's and 5 T's. 5 H's and 5 T's are nothing but what? These are reversible causes of cardiac arrest. What are the 5 H's? Hypoxia, hypothermia, okay? Hypokalemia, hypovolemia, hydrogen ion acidosis, and hypo and hyperkalemia. What are the 5 T's that we need to remember? 2 T's related to the heart, 2 T's related to the lungs. So 2 T's related to the heart are what? Cardiac tamponade, or coronary thrombosis. Cardiac tamponade or coronary thrombosis. Two T's related to the lungs are what, guys? Thrombosis. Thrombosis of what? Pulmonary thrombosis. And one T is what? Tension pneumothorax. Last T is what, guys? Toxins. Toxins have to be ruled out. These are the reversible causes of cardiac arrest that could be managed. So guys, remember, this is the chain of survival. If you are performed this chain of survival, then the chances of survival of the patient would be high. In previous chain of survival, we used to have till here. Now in the new chain of survival, according to the guidelines, what is being added now? Recovery is being added for the chain of survival. Recovery is being added. Okay. Now, guys, imagine you have given your you are giving CPR to the patient and you have achieved ROSC. ROSC is nothing but return of spontaneous circulation. Pulse is positive now. What you will do, you stop your CPR, and after stopping CPR, you manage ABC. ABC is what? You look for the airway, whether his airway is patent or not. Next, you look for the breathing and you look for the respiratory parameters. And next, you look for the hemodynamics. In the airway, you have to check whether he's patent, he's breathing with he's breathing or he's breathing spontaneously, or he requires something intubation or not. Next, breathing. Next is respiratory parameters. In the respiratory parameters, what we need to do is you look for the saturation as well as PCO2. Saturation should be how much, guys? 90 to 98%. It doesn't mean that if 100% is there, it is abnormal. No, minimum it should be 90 to 98%. And PCO2 value is 35 to 45 mm of Hg. That is very, very important. Okay. Next, hemodynamics. The BP should be what, guys? The map you should be, your target should be, I should have a map of more than 65 mm of Hg, and systolic blood pressure, it should be more than 90 mm of Hg. Again, you can achieve this hemodynamic parameters by adding some drugs like adrenaline, noradrenaline, vasopressin. Anything could be added. Okay. Once you achieve ABC, then you take a 12-lead ECG, and if there is a problem in ECG, send the patient to a cath lab. If there is no problem in ECG, then you need to assess whether the patient is awake or not, whether the patient is conscious or not. If the patient is not conscious, then the management is different. What if the patient is not conscious? What will you do? If he's not obeying your commands, you have to maintain a target temperature monitoring. How much temperature? Very, very important. 32 to 36 degrees Celsius. Target temperature monitoring basically reduces the cerebral metabolic rate. Hence, the brain uses less oxygen. Then you obtain a brain CT as well as EEG. Is this in clear? If he's obeying command, again, for obeying command also, you have to shift to ICU. Why? Because he had a cardiac arrest event. Okay. This is regarding what, guys? This is regarding the, if you have achieved the ROSC. Next, a patient presented on the ER in unconscious state, found to be hypotensive, dyspneic, and altered mental status. ECG reveals narrow QRS complex. What is the next best step? Guys, remember, basically narrow complex tachycardia he is asking. Narrow complex tachycardia. Guys, remember, if the patient is having tachycardia, tachycardia should be always divided into what? Whether it is stable tachy or whether it is unstable tachy. Okay? Because if the patient is having unstable tachy, when do you call the patient is having unstable tachycardia? When the patient is having HASIA signs. You know what is HASIA signs? HASIA is nothing but hypotension. A stands for altered mental status. S stands for signs of shock. I stands for ischemic chest discomfort. And A stands for acute heart failure. These are signs of instability. Okay? Because if the patient is having unstable tachycardia, such as in this case, the patient is hypotensive, dyspneic, altered mental status, those are all signs of instability. So what is the best management for unstable tachycardia? The best management is synchronized cardioversion. In cardiac arrest, unsynchronized cardioversion is given. In here, you have to go for synchronized cardioversion. But if the patient is having stable tachycardia, then stable tachycardia has to be classified into whether it is a narrow complex tachycardia or wide QRS tachycardia. Because narrow is different management and wide is different management. If it is a narrow QRS complex tachycardia, the best management would be what, guys? You have to go for VABC. V is nothing but what? Vagal maneuver. If by vagal maneuver the patient is not been managed, then the drug of choice for management of tachycardia is always what, guys? It is adenosine. Very, very, very important. Usually for narrow and wide, we are giving wide. There are more drugs even, but drug of choice for tachycardia management is adenosine. And what is the dose of initial dose of adenosine? 6 milligram. If it's not reverting, then 12 milligrams. So remember, guys, management of unstable tachycardia is synchronized cardioversion. Just now we have discussed. Okay. In case of stable tachycardia, the treatment of choice is first VABC. V stands for vagal maneuver. A stands for adenosine. Initial dose 6 milligram. B stands for beta blocker, and C stands for calcium channel blocker. Okay, that is regarding what, guys? That's regarding the tachycardia management. When is this position used? This is basically a recovery position. Recovery position is used when the pulse is present, breathing is present, but no consciousness. If the patient is having pulse and breathing, but he's not conscious, just keep the patient in this position so that he does not aspirate and all. Okay. A 70-year-old patient post-operatively develops fever, tachycardia, hypotension, lactate value of 5 millimoles despite fluids. MAP of 50, urine output is also reduced. Which drug should be considered? Which additional drug should be considered? Basically, remember, guys, what should be given over here? If the patient is showing the signs of, here the patient is having what? Lactate high means there is septic shock features. So in septic shock features, what we need to give, the best thing to increase the BP first by fluids. If fluid is not increasing, then what you need to do? Come on, guys. If fluid is not increasing, what's the next step? You go with norepinephrine. If norepinephrine infusion is not working, then you add what? Vasopressin. Very, very important. If vasopressin is also not working, still you add, norepinephrine is not working, you're not discontinuing it with norepinephrine, vasopressin. If vasopressin is not working, adrenaline. And you can also add hydrocortisone infusion, if at all, hydrocortisone 200 mg of infusion if the patient's cardiac output is low. Okay. So what's the answer over here, guys? The answer is norepinephrine. If fluid is not working, the first choice is norepinephrine. With norepinephrine, vasopressin. With vasopressin, you can add what? Adrenaline and give to the patient. Is this thing clear, guys? Yes or no? Okay. Match the following substances with appropriate antidotes. Benzodiazepine. What is the antidote for benzodiazepine? Benzodiazepine. If you have given a higher dose of benzodiazepine, there should be a reversal agent for benzodiazepine, which is what? Which is flumazenil. Very good. For alcohol, what is the antidote that is being available, guys? Alcohol, it is fomepizole. For opioid, what is the antidote that we commonly use? Naloxone. And for arsenic, we are using what? BAL, chelating agent. Is this thing clear? Okay. So these were the important points, guys. Is it clear? Okay, I had tried to cover most of the topics which are important for INI-CET. Is it clear, everyone? Okay. All the very best for your exam. Study well. Don't take any load. Don't take any pressures. Be motivated. Motivate yourself. Whatever, in which form you get it. But get yourself motivated and then study. Okay. Okay, chalo, ठीक है, done. If you are having any doubt regarding anything, guys, you can get connected with me on this. Okay? Even though I have been getting complaints that I am not responding, but whenever I get time, I will respond, guys. Okay? Right? Whenever you are feeling low or something, you can message me, guys. Okay? Done. Thank you.